अशोक कुमार।
अशोक सर कैसे हैं?
नमस्कार कुलदीप जी, डॉक्टर स्नेहा मैडम नमस्कार।
Hello, sir. Good evening, Dr. Ashok. Welcome.
Madam, we are live now. Right? We are live.
Yeah.
Yes, sir.
Okay. So we are starting the program. So good evening, doctors and all the participants. I, Dr. Suman, on behalf of Shield Healthcare, welcome you all in today's session on AMOGS Medical Disorders Committee with Surat, Baroda, Himmatnagar and Palanpur societies. And today's topic is anemia, heart disease, thyroid disorders during pregnancy. Now it's my honor to introduce the convener of today's program, Dr. Archana Divedi Madam, Madam Dita MD, DGO, FICOG, CIMP. She is the National Chairperson, INS Website Committee, 2023 to 25, President DOGS, 21-22, President, Founder, President MSD, 1920, Secretary
From here. I think we'll take it from here. We all know each other well now.
Okay.
So,
thank you very much, ma'am, and over to you for further process.
Thank you so much for this kind introduction, and it gives me a very honored and privileged moment for me, inviting all those esteemed faculties I can see streamlining in front of me for this another yet educative session. The preamble, I would invite Dr. Sneha Bhuyar, Madam, who has taken all the pains, and she has created this learning series, and I've been, myself and Kirtan have been the co-conveners with her, and have been enjoying the academic feast, and yet we are again to start another fresh one today. With esteemed guest, Dr. MC Patel sir is here, Prakash sir is joining in a while, and Dr. Desai will join us in a while. Over to you, Sneha Bhuyar, Madam, to introduce and welcome for our welcome speech.
Yeah. Saiti, I think you can stop sharing. I'll just welcome everyone and then we go for lamplight.
Okay.
So, very good evening, one and all the respected dignitaries, especially Dr. Pankaj Desai sir, who will be joining in a short while, Dr. MC Patel sir, and Dr. Prakash Bhatt sir. My amongst office bearers, Dr. Pardesi sir and Madam Sujata Dalvi, who are traveling to Nasik, so they may not be able to join for today's program. And of course, today's faculties and all the presidents and secretaries of the society, Surat, Baroda, and of course Palanpur and Himmatnagar, and all the speakers for today's program, Dr. Ashok Kumar, Dr. Murlidhar Pai sir, Dr. Girija Wagh, my dear friend, and Dr. Kuldeep Singh. Welcome, sir, Dr. Murlidhar Pai sir. A very good evening to all of you and a warm welcome to you. Me as chairperson of the AMOGS Medical Disorders Committee, welcome all of you for this learning series on medical disorders of pregnancy. And we have been covering various societies of Gujarat, and of course, almost all the medical disorders of pregnancy have been covered till now. Today we have anemia, heart disease, thyroid disorders during pregnancy. So I welcome all of you here, and without much ado, I hand over to Dr. Archana for the further proceedings. Here, Saiti, you can go ahead with the lamp lighting and we can go ahead with the program. Yeah, over to you, Dr. Archana.
Thank you so much, ma'am, for this welcome. And let us remember God before we start this session. Saiti, can we have the prayer of introduction?
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhanasampada Shubham Kurutvam Kalyanam Arogyam.
Thank you, Saiti, for this brief prayer. And we have got our guest of honors, Dr. MC Patel sir is here. It gives me immense pleasure to introduce sir, who is the Vice President of Proxy 2018, Organizing Secretary of AIC 2017, Chairperson Ethics Medical Legal Committee 2011-13, and Honorable Joint Secretary, State Organization of Gynecologists and Obstetricians of Gujarat 2019-22. Honorable Secretary Sogo, Gujarat 22-24, and Organizing Chairperson MMCon 2018. Honorable Member, National Inspection and Monitoring Committee, PNGT Act, Government of India 2015, and Honorable Member, State Supervisory Board, PNGT Committee, Gujarat State 2005-9. President, Ahmedabad OB Society 2010-11. Honorable Member, National Managing Body, Indian Red Cross Society, and National President, National Medicos Organization 2016-18. President, IMA Ahmedabad Branch 2007-8, and Honorary Surgeon, Indian Red Cross Eye Bank collected more than 1,000 eye pairs. He is also the organizing chairperson, Vivekanand and NMOCon 2013, and President of Lions Club, Gatlodia, Ahmedabad 1997-19. We welcome you, sir. There is one Iron Man known for, we all know from Gujarat, and he is another white man who is at a rescue for everybody. A very friendly personality, this is my personal opinion, and die-hard learner and wants to teach us so much. And I have been part of his learning webinars also. Over to you, MC Patel, sir, for blessings for this webinar and the start.
Thank you, Archana, for kind words. It gives me immense pleasure to be with all of you, and let me congratulate Dr. Sneha for nicely organizing this webinar with Surat, Baroda, Himmatnagar, and Palanpur, and subject chosen very aptly: anemia, heart disease, and thyroid disorders. Because we know, as far as any pregnancy case is concerned, when it is added with any comorbidity like anemia or heart disease, whether it is valvular or non-valvular, and cardiomyopathy also, and thyroid disorders, hypo or hyper, our responsibility as an obstetrician and taking care of any pregnant patient becomes increased manifold. And we should be very vigilant in this type of situation. And many times I share during my medical talk also, we gynecologists friend have either no habit to put stethoscope on chest of patient, and many a time important cardiac disease we miss, because in one of the cases which happened, everything was fine, cesarean section was done, baby was delivered, and on 8th day she had breathlessness. She was admitted in ICU, and she was diagnosed as a tight mitral stenosis. So this type of mishap, if at all happens, you cannot be pardoned. So we should be very vigilant as far as our care to be taken for any patient is concerned. And she has very nicely invited all the Legion faculty, and they are very much Legion in their respective field. I see Dr. Muralidhar Pai, and he is going to discuss about etiopathology screening for anemia. And we know, as far as anemia part is concerned, and management is to be covered by Dr. Ashok Kumar. And as far as anemia is concerned, Government of India is very much keen to take care of any of our anemic patient, and no patient should be anemic, particularly at the time of pregnancy, is the motto of government. And FOXI also, this year, no anemia, go anemia, anemia fi Bharat, anemia mukt Bharat. So whichever slogan we have, but ultimate goal is to check anemia and to make our patient safe. And as far as heart or cardiac problems are concerned during pregnancy, Sneha herself is going to talk, and I have heard her for this talk, and she is nicely covering this subject. So it is good for this program also. And as far as thyroid dysfunction is concerned, Dr. Girija Wagh, one more good faculty and very good academician, she is also going to cover this subject very nicely. And Kuldipra, fetal medicine master, is going to cover fetal heart, and it is our duty to check fetal heart also, because if at all there is something goes wrong as far as fetal part is concerned, then also it becomes a very difficult situation to face before patient, before relative of patient, and in court of law if at all litigation happens, then before honorable court. So very nicely chosen all the topics for today's webinar, because they are very topic of today's concern in our day-to-day obstetric practice. So thank you, Sneha, for inviting me to be part of this webinar, and all the best for success of this webinar. Thank you very much.
Thank you, MC sir. Madam Sneha ma'am is on mute. Thank you, sir, for the blessings. And I can see Dr. Prakash Bhatt sir has also joined. Sir, a few words of wisdom from your side. Sir is a past president of Surat Obstetric Gynec Society, and under his leadership, he also got the Best Society Award. Vice President Foxy for 2005, ex-chairperson of Rural Obstetric Committee Foxy, received Distinguished Community Service Award for Columbia University, New York by International Federation of Obstetrics and Gynecology. First Indian to receive this honor, so claps to and a proud moment for Gujarat also, sir. Conceived and executed Foxy programs on emergency obstetric care training with John Hopkins University and MacArthur Foundation, and later on with Government of India in 2003. The program ended in 2017. We welcome you, Prakash sir, and let me introduce you as a young at heart and a forever young man with his brilliant dressing sense, and we remember you for that. Surat is again hosting again, and we are looking forward to meet you in the zonal conference. Sir. Over to you for the words of wisdom.
Archana, sorry to interrupt. One word I would like to add: ever ready battery for Surat all OBGY practicing doctors.
Yes, I completely agree to that.
Yeah.
He is a source
Welcome,
of
sir. Welcome.
so news. Welcome, sir.
Thank you, Archana Ben. Thank you for the last sentence, especially of that young and the youth. Really made me young, at least today evening. Anyway, I wish the program all the success. May you achieve what you people have set out to achieve, not simply for this program, but whatever that has been planned in future, similar such programs. The medical disorders and the pregnancy have been quite known to us and have at times frightened us also during practice, right, Manubhai?
Yes.
And have at least we had to run for the shelter under Manubhai Patel at times because of medical disorders only. So, however, more the knowledge, probably more attentive and more cautious we would be. Once again, I wish all the success and a grand reception for this program all over the Foxy world and the Foxy generation. Thank you very much.
Very good, Prakash. You have rightly mentioned everything. And as far as this webinar is concerned, Sneha has very nicely organized this. And I know her since long working in Foxy. And she is also with me in my series of happy learning.
Sir.
She is very deserving person. She is contesting for the post of Vice President Foxy this year. And I have promised her wholehearted support from all over Gujarat. And now it is duty of Gujarat to fulfill my promise to her.
Yeah, perfectly,
Thank
sir.
you.
Thank you so much, sir. Thank you. Thank you for your blessings and support, sir.
Thank you so much, sir. Dr. Desai sir is in the middle of a surgery. He'll join us in a while. So we move further. Dr. Kirtan, you can take over from here.
Yeah, as stated, because of the mock state conference, Dr. Pardesi and Dr. Sujata, both of them are traveling to Nasik, and they're not able to join for today's program. Maybe meanwhile, if at all possible, they may just join and bless us. So I think we can go ahead with the academic session. So I would just like to thank all the dignitaries, especially Dr. Pankaj Desai sir, Dr. MC Patel, Dr. Prakash Bhatt sir, all the speakers, the faculties, chairpersons, panelists, and all the presidents and secretaries of Surat, Baroda, Himatnagar and Palanpur societies. And now I think we should go ahead with the academic session. Thank you so much, and over to you, Dr. Kirtan.
Yes. Again, we welcome all of you. And without wasting a minute, we would go ahead with the academic session, the first session ever on anemia. And for the session to chair, it gives me an immense pleasure to invite our esteemed chairpersons, Dr. Binal Shah. She has been a national chairperson of Indian Menopause Society and Club 35 Plus. And she has been the past president of Baroda Obs and Gynae Society. And she has been a gold medalist career throughout her in Amas University. So we welcome you, Madam, Dr. Binal Shah, Madam. We have with us Dr. Meenakshi Patel, Madam. Yes, she has been the director and consultant of Sunshine Global and Baroda Hospital, and she has been the past president of Sogok and Baroda Obs and Gynae Society, and she has received Gujarat Gynae Excellence Award in 2020, and has been the presently Foxy representative and secretary to Menopause Society. Also, Madam, Dr. Meenakshi, Madam, we welcome you. We have with us Dr. Mahendra Soni, sir. He has been a senior practitioner in Himatnagar since 1984. He has been the founding president of Himatnagar OB-GYN Society in 1994 and has been the Sogok president in 1995. He has been awarded an oration at Sogok conference, which was recently concluded at Bhuj in 2021. So we welcome you, Dr. Mahendra Soni, sir.
Thank you, Dr. Kirtan. It really gives me immense pleasure to chair this session and would like to congratulate Sneha Bhuyer ma'am, Dr. Archana and Dr. Kirtan for putting up this webinar. And this is actually truly the need of the hour. Medical disorders, where the physiology of pregnancy is being challenged by the pathology and the comorbidity of other medical problems. And it is truly a baffling task for the obstetrician to balance both. And we have excellent speakers today to give justice to the topic. Anemia is a major killer and a major contributor to the maternal mortality. And today to talk on this topic, we have the Professor Murlidhar Pai, who is the Dean of Sikkim Manipal Institute of Medical Sciences. Sir has given contribution to the academic field for more than 35 years. He has more than 20 awards to his credit, 15 international fellowships, 200 plus publications, and sir has given talks at more than 700 plus occasions. Even he has 2 textbooks to his name. So we welcome Dr. Murlidhar Pai, sir, to please enlighten the audience on this topic of etiology of anemia and how to move forward with a patient with anemia. Thank you so much.
Thank you, Dr. Binal, and I thank Dr. Sneha for giving me this opportunity to interact with so many societies which are very dear to my heart. My greetings to all the members, delegates here, and my pranams to Dr. MC Patel, sir, who has been a guide for me throughout the years, and also Dr. Prakash Bhatt, sir, and all others here. Today, I will straight away get into my topic, anemia in pregnancy, etiology, and screening. Of course, we all know that anemia is a very, very important aspect in the medical disorders affecting pregnancy because it is responsible for 20% of maternal deaths in India, according to research statistics. The incidence is somewhere between 40 to 80% in tropics. That's quite high. And in developed countries, it is 10 to 20%. So anemia is not only the problem of a underdeveloped or developing countries, even in developed countries, maybe because of the mismanagement in their food diet habits and other things, or maybe due to physiological reasons, 10 to 20% of anemia can be seen even in developed countries, which is again quite high. Generally, we say that any disease that is less than 10% is okay, but when it crosses 10%, it is definitely a cause of concern. So it is not only the cause of concern in the third world or second world countries, it is a cause of concern even in the first world countries, like Western countries, America and Australia, Singapore, anywhere you go. In India, iron deficiency anemia, as per ICMR estimate, up to 60%, 2/3 of women will have this, which is alarming. And WHO says it is around 42% across the globe. That's exactly why Indian government has come up with the programs like Anemia Mukt Bharat. So we all have a very big contribution to make. And it is such a common topic, and a common topic for not only undergraduates, postgraduates. It is seen by all clinicians day to day. So much is talked about it. Sometimes what happens, when you talk too many times about a common problem, you get tired of listening to that again. So I try to make it slightly different and interesting if possible. So all of us know the definition. The quantitative and qualitative definitions are different. So qualitatively, we don't, what do I mean by qualitatively is we don't go by a particular level of hemoglobin. Just qualitatively speaking, it is nothing but decreased oxygen carrying capacity of the blood. Now, for some of us, even at 12 grams, there can be decreased oxygen carrying capacity. Even a healthy person, when they come to like northeast part of your Sikkim, or when you go to North Sikkim, especially then, even if your hemoglobin has been very good, there can be decreased oxygen carrying capacity. So you may have symptoms similar to anemia, even though you are not anemic quantitatively. So due to decrease in amount of RBCs or the oxygen carrying capacity, which indirectly is seen in terms of hemoglobin, and the cutoff is 11 gram%. Many undergraduate students think that 10 is okay, but it is not 10, it is 11. So that has to be understood very clearly. So it can be both because of the absolute number of RBCs, or maybe even the numbers are there, their hemoglobin content is less. That will also give rise to problem of anemia. That's what I said. There can be a situation of having both decreased numbers as well as decreased hemoglobin. We need to understand the classification before we understand the etiology, because there is so much we can understand from the classification itself as far as the etiology of anemia is concerned. The most common etiology is deficiency. That is the nutritional deficiency. It can be isolated or combined. Now, this is the reason why anemia is seen both in developed countries as well as underdeveloped countries. The deficiency is not only because of the scarcity of the particular nutritional food substances, it also can be because of the ignorance about what to eat and what not to eat, and how to eat in combination of different things. So the deficiency can be iron deficiency, folic acid, vitamin B12, especially in pure vegetarians. We can see this vitamin B12 deficiency. Now, this person may be very intelligent, educated, he knows everything about it, but since he's a pure vegetarian, there can be sometimes deficiency of vitamin B12. Though they say it is very, very less, but when you investigate, you can see this, and just injections of vitamin B12 will see the dramatic improvement in these kind of women. Then, of course, hemoglobin, which itself suggests that heme is combined with globin, which is a protein. So protein deficiency is always there in iron deficiency. It's always iron plus protein deficiency that gives rise to anemia. So as I said in the heading itself, it can be isolated or combined, but usually it is combined deficiency of iron, folic acid, vitamin B12, and proteins. Hemorrhagic, yes, it plays it's not only classification or categorization of the acquired anemia. This classification gives us a clue towards the etiology of anemia. In pregnancy, you may see anemia, but if you ask history, this particular lady must have been having heavy bleeding during her menstrual cycles. So to start with itself, she may be anemic. So it can be after pregnancy, which is related to the pregnancy, that is the antepartum hemorrhage. It could be postpartum hemorrhage, which is acute, of course, and chronic hemorrhage, which is sort of incipient loss, insidious loss. We don't realize this. It is not dramatic loss, but it is because of infestations. We all know about the hookworms and pinworms and all that, which suck blood. In the exams, the examiners used to ask how much blood is sucked by each of the these particular worms. So they are sucking blood every day, and that's why we are actually bleeding into them. But it is not so dramatic as APH or PPH. Then we can have hemolytic due to malaria, dengue. Of course, dengue gives rise to platelet deficiency, but malaria definitely gives rise to iron deficiency or RBC loss because of the breakage, hemolytic anemia. Bone marrow insufficiency. This can happen due to the side effects of the radiation, drugs, and infection. So all of them. So this slide is heading is classification, but I can change the heading as etiology of anemia as well. So to summarize, it is deficiency, hemorrhage, hemolysis, or bone marrow insufficiency. Now, after acquired, we should also look at the hereditary causes or hereditary etiology of anemia. Hemolytic, it could be not due to infestations or due to infections like malaria. It could be familial hemolytic anemia, which is hereditary spherocytosis. RBC membrane defects. So the RBCs will break easily. It can be hemoglobinopathies. I'm going to talk in the end a little bit in elaboration on these things, but then again, it comes under hereditary problems. For example, sickle cell anemia. Once I thought sickle cell anemia is common in Africa and other things, but we can see sickle cell anemia in India as well. Especially thalassemia is not that rare at all. When I was in Manipal, I used to see lots of cases referred from Kerala to have this kind of thalassemias. Aplastic or hypoplastic anemia is also hereditary, has got hereditary roots in them. So let me now elaborate on the nutritional anemia, which is due to deficiency. But we need to understand which food substances contain iron and iron metabolism a little bit, how it is being absorbed or secreted or utilized by the body. The heme iron is mainly present in animal flesh and viscera. For example, liver, red meat, chicken, fish, and eggs. So those who take non-vegetarian, they get plenty of supply of heme iron. So which is almost like a ready-made iron, heme iron. The absorption is also not very difficult. They are easily absorbed, but may increase the risk of cancer, stroke, heart disease, and metabolic syndrome. That's why now entire world is turning towards vegetarian diet, other than those who are used to non-vegetarian diet. Absorption is not affected by inhibitors because it's already, like as I said, it's a heme iron. So you don't have to worry about whether other food substances will affect their absorption. It is not affected by any inhibitors. Whereas there is another main category called non-heme iron. What is this non-heme iron? It is mainly seen in plant foods, vegetables, cereals, and beans. Okay, so vegetarians also have a good news. They don't have to worry that they don't get iron. They get iron in the food that they consume, but they are not well absorbed. That is the problem, and can be increased by enhancers and decreased by inhibitors. That is what I meant earlier, that combination of the food. For example, you may be eating iron-rich food, but then you are also mixing some other phytates, which will hamper the absorption. Whereas if you add nimbu, then the absorption is increased. So that's what I mean by they are not well absorbed, but it can be increased by enhancers and decreased by inhibitors. So this much education is very important to understand how we can prevent anemia just by diet modification. Now, what are these enhancers and inhibitors? Let me elaborate on that. The enhancers of heme iron proteins meet ascorbic acid, ferrous iron. Ferrous iron is the best, but it is the cheapest. That's why many companies are not interested in the tablets of ferrous iron. But other all combinations they would like to produce. Gastric acid, we all know about the achlorhydria can hamper the absorption of iron. Alcohol, of course, I am not promoting alcohol just for the sake of enhancement of absorption of iron here. Low iron stores, it's like starvation. When you are very hungry, you have a tendency, that's what the pica is due to. Pica is because of the low iron stores. You can eat anything and everything and try to find some iron in that, including mud. Increased erythropoietic activity. So when there is increased erythropoietic activity, you need the raw material iron. So that itself is like, it's like a gradient. When there is low iron, obviously that attracts more iron. So these are all included under enhancers. Let us look at the inhibitors. Phytates, as I just now told you in the previous slide, phytates, calcium, that's exactly why iron tablet and calcium tablet should not be taken together. Let me repeat this. Iron tablet and calcium tablet should not be taken together. Sometime back, few years back, one company came up with single tablet which has got both iron and calcium in a single tablet. I heavily objected for that. And then the representative, of course, who came and met me, he wouldn't understand that. Then I wrote a letter to the company saying that this is the worst possible combination you can have. That is iron and calcium in the single tablet. Iron should be taken, suppose you take iron in the morning, calcium should be taken in the afternoon. Why I'm preferring calcium in the afternoon? Because it is absorbed better in the afternoon, because afternoon you get free vitamin D from the sun. And then, of course, in the night again, you can go for iron. Iron ideally should be taken on the empty stomach, ideally. But then no woman will tolerate iron on the empty stomach. That's why they take usually after maybe food, but that is not well absorbed. But if it is taken on empty stomach, there will be a lot of gastric irritation and things like that. It is like a balance walk that we have to make. Tannins, tea, and coffee. So please don't take iron tablets with coffee or tea. Plain water is the best to swallow the iron tablets. Even any milk products, for example. So they will inhibit milk, of course. It is very easy to understand because they contain calcium. So you should not take iron with the milk and milk products and calciums and phytates. Now, though it may be very academic and boring, I have to have one slide on absorption and metabolism of iron. Absorption is mainly in the duodenum. That's exactly why most of the tablets that we have in the market, they say it is not disintegrated in the stomach. It is intact in the stomach, but it will later get disintegrated in the duodenum and down the ileum and jejunum. So that's why such entry-coated tablets are available, because they are released only in the duodenum and jejunum. Probably they have understood clearly that the absorption is better in duodenum and proximal jejunum. Only 10% of dietary iron is absorbed normally. Rest of the requirement should be substituted by oral iron. Many ladies ask us, I'm having very good food, very rich food in iron. I've understood everything. And there are plenty of nutrition specialists and dietary specialists. They advise them. Because somehow we don't mind eating 3 times a day, every day, year after year. But if you are asked to take a tablet, somehow that is not acceptable to any one of us. We don't mind taking peppermint every day. We don't mind taking chocolate every day. We don't mind eating sweets every day. But we don't want to take tablet every day. That's why we have to convince and counsel the patients, dietary iron is fine, very good, but it is not absorbed fully. Only 10% is absorbed. Even when we give substitutional iron, let's say 60 milligrams of elemental iron is given in the form of tablet containing 200 milligrams. But out of that again, only 10% is absorbed. 6 milligrams is all that is absorbed. For having 6 milligrams of iron, we have to take 60 milligrams of elemental iron tablet. So both dietary iron as well as tablet iron are absorbed very, very less. This has to be highlighted. The metabolism is balanced by hepcidin, that is hormone secreted in the liver. Any lady having disorders of liver, especially during pregnancy, their metabolism is hampered or it is abnormal. Ferroprotein, iron exporter protein. So if you have good ferroprotein, then it is nicely transferred across. Erythropoietin, all of us know erythropoietin is a single factor which determines whether the lady will have anemia or not. We all know it is secreted, produced by kidney and by the liver. That is 10% comes from liver, rest of it comes from the kidney. So this erythropoietin factor is reduced in urinary tract infection. I used to ask the undergraduate students, what's the connection between urinary tract infection and anemia? Then, of course, they wouldn't know the answer, but the answer is in erythropoietin. Whenever there's urinary tract infection or damage in the kidney, erythropoietin factor is not produced, and they will have chronic or what is called refractory anemia. So unless you treat urinary tract infection, how much ever iron you give, it is not being absorbed or it is not being utilized. So increased in pregnancy due to placental lactogen and progesterone. So that's why that is a good thing. And it increases the red cell volume by stimulating stem cells in the bone marrow. So erythropoietin is a very, very important factor. Fortunately, it is increased during pregnancy by placental lactogen and progesterone, and it increases the red cell volume also. So this slide, though looks purely academic, it is very, very important for us to understand. Otherwise, we'll be simply prescribing iron tablets without understanding that the lady has got other problems, and unless we manipulate or we correct those problems, she is not going to improve at all. And finally, we may resort unnecessarily to blood transfusion and other things. So this exactly is a picture wherein you can see the interplay of all the things. I don't intend to explain this at all. As you can see, hepcidin comes from liver. Then there is a ferroprotein which tries to transfer across, as I told you. And then there are, of course, it is happening all in the duodenum. And finally, the iron that we take either from the food or from the other things, it is converted from F3T to F2 and then lost by shielding of epithelial cells. So now pregnancy is a peculiar situation where there is what is called physiological anemia. One may wonder, anemia itself is pathology, which is decreased and oxygen carrying capacity. Why do you call it physiology? Now, it is called physiological anemia because of the changes or physiological changes that occur during pregnancy. Otherwise, this lady, if you do her hemoglobin estimation in a non-pregnant situation, it comes out as normal. It is seen usually after 20 weeks because after 20 weeks, there is what is called hemodilution. We all know everything increases during pregnancy. This is one simple common general formula I give to undergraduate as well as postgraduate students. Simply remember, what are the physiological changes in anemia? Most of the things are increased, barring few things. So there is increase in the blood volume. Blood volume means both plasma as well as cell volume. But the problem is the plasma volume is increased more than the cell volume. So obviously that is dilution. That leads to dilution of the given cells in the given plasma. And this is maximum during around 32 weeks. That's exactly why that time you can see anemia more. Even that's the time when we see cardiac failure and other things. So it's basically after 20 weeks. And there can be negative iron balance because now the lady is utilizing iron most. Even the fetus also must be trying to snatch or steal some amount of iron from the mother. But how do you say that it is physiological and not gone into the domains of pathology? One single important thing is that hemoglobin is never less than 10 grams. If it is less than 10 grams, means in addition to physiological anemia, there is a pathological component. That's what has to be understood. I hope I'm clear. If it is only physiological anemia, it can never be less than 10 grams. The second thing, PCV is never less than 30%. So if it is less than 30% means there is a iron deficiency anemia. And of course, the picture in the peripheral smear is normocytic, normochromic. There is no hypochromic. Whereas in iron deficiency anemia, what do you see? We see microcytic, hypochromic. Here it is normocytic, normochromic, but it is diluted in the more plasma. I hope that's very clear. Now coming to iron deficiency anemia, all of us know about this. When the storage iron goes on to transport iron and the erythron iron, in the marrow it is 2 to 3 plus serum ferritin, it should be 150, saturation should be 40, and HCT is 45, and RBC morphology is normal. So there are 3 stages. So this is normal. Now, when there is depletion of iron stores, what happens is, as you can see here, it is slowly depleting in the storage. It is still okay in the erythron iron level. The marrow, it goes down from 2 to 3 to 0 to 1. Serum ferritin goes down from 150 to 120. Saturation goes down to 35. HCT is normal and RBC morphology is normal. But when there is iron deficient erythropoiesis, as you can see, the storage is almost white there. It is empty. Even the erythron is going down. The bone marrow iron is 0. Ferritin goes down less than 100. Saturation is less than 30. And now HCT goes down to 41. Still RBC morphology is maintained. But then frank iron deficiency anemia, when you have, as you can see, the storage is totally empty and white. I hope you can see my arrow. And then here also it is going down. And marrow, of course, was 0 earlier itself. Serum ferritin goes below 20. I usually ask the students to remember is in terms of ferritin 15. They sound rhyming, teen. So it is less than 15 actually, but even 20 is bad enough. Saturation also goes down to 20. And now, as you can see here, there is change in the morphology, that is microcytic, hypochromic. I hope this is very clear, the 3 stages of iron deficiency anemia. So iron hemostasis, if you see here, this is very clear. In the first side, it is iron overload, and in the second side, it is iron deficiency. Iron excretion, we need to understand 1 milligram of iron is excreted daily through various mechanisms like sloughing of the skin cells, shedding of the cells in gastrointestinal and urinary tracts. Iron from the old erythrocytes can be recycled and absorbed to formation of new RBC. So every day we lose iron without our knowledge. It is not dramatic. It is not like bleeding. But without our knowledge, we are losing iron every day. Of course, some part of it is reabsorbed to formation of the new RBCs. So what are the causes in general? As I already told, faulty diet, rich in phosphates and phytic acids, faulty absorption, maybe infestations and hypochlorhydria, iron loss in terms of menorrhagia, infestation, and malaria. In pregnancy, additional factors I'm talking, increased and abnormal demand both from mother and the fetus, diminished intake and disturbed metabolism, which we have already seen, and pregnancy itself competes with folic acid, vitamin B12, and proteins. This is the most important thing to understand. Now, we said for hemoglobin formation, I will show in the other slide how folic acid, vitamin B12, and proteins are important. Protein is, of course, hemoglobin, means heme plus globin. Globin is protein. Now, these 3 ingredients, folic acid, vitamin B12, and proteins, are also needed for the baby. They are like cement for the babies. Baby is also actively absorbing and actively demanding these things. So where is that for the correction of anemia. So that is what is meant by pregnancy.
Dr. Muralidhar, sorry for interruption.
Yeah, I can
You
finish.
will have to cut short, yeah, because
Yeah, I finished with this. So, and this is by probably last but one slide. The nucleic acid metabolism, as I told you, vitamin B12 is important in converting pyrimidine base to uracil. And we know folic acid is very much required to make it folinic acid, where vitamin C helps. And both of them together, and along with thymine, they help in formation of RNA. So this is where the erythropoiesis, which is confined to bone marrow and continuous process and raw materials like iron, copper, vitamin C, Fa, and B12 is required for protein and erythropoietin. So that's what I would like to say and conclude by saying that the most important etiopathogenesis in case of iron deficiency anemia in pregnancy is not just the iron, but all of the nutrients background to start with. And that's how we have to be very, very important in understanding things. I hope I have just highlighted few points.
Thank you, sir. It was an excellent deliberation as always. I would request Dr. Meenakshi ma'am and Dr. Mahendra Soni sir to give the concluding remarks.
Hello. Thank you, sir. Wonderful. Am I audible, Archana?
Yes, ma'am. Yes, ma'am.
Thank you, sir, for the wonderful presentation. Anemia usually commonly occurs during the pregnancy is usually due to the nutritional deficiency, iron, vitamin B12 and folic acid, and specifically chronic infections, helminthic. So WHO also says that recommends that albendazole is to be given either in the first or the second trimester, as a national guidelines also says that iron supplementation decreases the prevalence of the microcytic anemia. B12 and folic acid supplements decreases the prevalence of the macrocytic anemia, and multiple deficiency due to poor intake and screening of all the patients in the first trimester has to be recommended by the WHO. And usually is the diagnostic various screening tests in the first trimester that will say us which type of anemia is there. And sir has extremely explained regarding the things like that, which type of the food and it is to be taken with which food, so that the absorption of the iron can be increased. Thank you. Now sir will give some remarks regarding that. Soni sir, please.
Thank you, Dr. Muralidhar. It was really excellent lecture. I'm sorry for interrupting, but
No, not at all. I was about to finish
the
anyway.
subject is so long, you know. I know that it's very difficult to complete etiology, pathology, and all these things in a nutshell, but you have done in a very lucid way. Particularly the iron absorption and whatever points that calcium and iron, because you know many times pharmaceuticals people comes and they just say that yes, we can give all these things together. Our tablet can be given even with calcium. Our tablet can be given with food also. But you know, basics remains the same. And one important thing which you elaborate is ferrous salt. You know, I definitely believe that 25 paisa or 50 paisas ferrous tablet is equally good.
Yes, sir.
Whenever a high-fi iron salt people come with, and it is nowadays, you know, today only I had a representative who said that this tablet is costing 25 rupees per one tablet. You know, in 25 rupees we can give even a whole month's iron also.
Yes, correct.
So really, thank you very much for completing many factors in a nutshell. Thank you very much.
Thank you, sir. Thank you, Mahendra Soni sir, for the excellent compilation of the talk. And the crisp messages will be long-term benefits to all of us as a practitioners. Thank you, Muralidhar sir, Pai sir. Thank you, Meenakshi ma'am, Mahendra sir, and Vinal for the excellent session. Moving forward to the session 2, it gives me immense pleasure to invite Dr. Amita Shah, madam, our President BOGS, Dr. Sayuj. So Dr. Amita Shah, madam, is currently practicing at a private hospital in Baroda since past 30 years and is presiding over as the president of Baroda Obstetric and Gynec Society. She has got a keen interest in adolescent health, menopause, and infertility. Her motto is to enhance women's health awareness and empowerment. So thank you. Welcome, ma'am, for chairing the session. Our next chairperson, Dr. Sanjay Gandhi, sir, is practicing at Aarti Hospital, City Gem IVF Center. He has done more than 7,500 IVF, attended many national conferences, President Foxy Palanpur 2009, and Zonal Representative Sogo 2013-15. Co-writer book IVF Made Easy is under his kitty, and he is also having diploma laparoscopic surgery from University of California, 1996. So we welcome you both. Dr. Sayuj is a secretary of Baroda Obstetric and Gynec Society, and he'll join us soon while the session is going on. So welcome, chairpersons. I would request Dr. Abhita Shah, madam, to introduce Dr. Ashok Kumar, sir, for his talk.
Yes. Thank you, Dr. Archana. It's my privilege to be over here. Well, we have a very learned speaker today, Dr. Ashok Kumar. He is the director and professor in health department of obstetrics and gynec of very prestigious hospital, Dr. Ram Manohar Lohia Hospital. And currently he's the secretary of Indian College of Obstetrician Gynecologist. May I invite Dr. Ashok Kumar for his talk, please?
Good evening. Am I audible?
Yes, sir.
Yes, sir.
Yes,
Yeah,
yes, sir.
yes.
Yes.
I would
Yes,
like
sir.
to start sharing, and just please confirm whether it is visible or not.
Now it is visible, sir.
Yeah. Okay.
So please put
First of all, thanks to the Dr. Sneha Buhar for inviting me and giving me this opportunity to present this talk on anemia. And I am thankful to Dr. Pankaj Desai, Dr. MC Patel, and Dr. Prakash Bhatt, our chief guest, then AMOX office bearer, and convener and coordinator of this program, and our chairperson, Dr. Amita Saha, and Dr. Sanjay Gandhi. So thank you very much for having me with you. I hope I will do justice to the topic, although it is a very vast topic, as you know, but still I would like to highlight few important points in the management of anemia. And you know, pregnancy is complicated with anemia. Usually it is the nutritional anemia, and I will be much more talking only on iron deficiency anemia. And you know, this Anemia Mukt Bharat program is being launched by the government of India. And now we all are following all these things. And Dr. Pai has already simplified most of the thing for me. So I just straight away go to the management instead of going into the details of how to diagnose and what all the presentations of anemia. See, we have to just start with the diagnosis, you know, and hemoglobin less than 11 or hematocrit less than 33%, or qualitatively, and there are grades also. And then we try to find out the type of anemia by RBC indices, MCV, MCH, and MCSC, and peripheral smear. And we try to find out the cause of anemia and then try to treat the cause. This is all our approach during the case. And there are a lot of investigations we do and to find out, but what we follow, we simply follow routine hemoglobin, then complete blood count, which include hemoglobin, then MCV, MCH, MCSC, and reticulocyte count, TLC, and platelet count. And then we try to do peripheral blood smear. And there's so many things we want to know on peripheral blood smear: morphology of RBC for type of anemia, hypersegmentation of neutrophils, hemoperocytes, evidence of hemolysis, and platelet count. With all these, we are satisfied, and in India, like because it is a very common problem, we just start with the treatment. But before that, we do screening for thalassemia, and if it is not a very common problem like North India, then one can straight away rule out thalassemia by doing the diagnostic test also. Now, iron studies, we are not doing at the start of the investigations. We are not. We are only doing iron studies to confirm the diagnosis in case woman does not respond to the treatment. Initially, because they are costly things, and by giving just iron, if we can improve the situation, then why not? But there are differences of opinion. Some are insisting on doing iron studies before starting iron therapy also. So it depends on the geographical places, conditions, and their hospital protocol, and the obstetrician also. So I will not strictly follow this, but yes, there is a variation on this issue. And now straight away, we just go to the treatment part. Just I want to highlight that requirement of iron deficiency for iron is 2 to 4.8 milligram iron per day in pregnancy. Now, usually 10 times is absorbed. So we have to have 20 to 48 milligram of dietary iron. Now, problem with us, India, is that our average vegetarian diet does not contain more than 10 to 15 milligram of iron, and phytate contains also in the diet reduces iron absorption, as highlighted by Dr. Pai also. So moreover, majority of the Indian women enter pregnancy already with iron depleted condition. Iron store is markedly reduced when there is a fall in hemoglobin values. Therefore, there is a need for routine iron supplementation to all pregnant women. So this is regarding the prophylaxis part. So that is why all pregnant ladies should have iron therapy, iron for prevention of anemia, iron prophylaxis. But what about the treatment part? Now, for the treatment part, this India Anemia Mukt Bharat program, they have highlighted that all pregnant women should have 60 milligram of elemental iron and 500 microgram of folic acid to be given daily, starting from 4th month of pregnancy, continue throughout pregnancy, minimum 180 days, and to be continued for 180 days postpartum. And this is important to understand, that to be continued for 180 days postpartum to replenish iron stores. This is very important. This is a change here, that 6 months after delivery, it should be continued. So this is for the prophylaxis, iron anemia, for prevention of iron deficiency anemia. But now what to do when there is a patient with iron deficiency anemia? Now here the dose is more. We have to give 180 to 200 milligram of elemental iron daily in divided dose and in between meals. As Dr. Pai also told, that it has to be given empty stomach, but sometimes the iron is not tolerant to the patient. So we advise the patient to take after meals also. Now, various iron salts are available. Easily available are ferrous sulfate. It has a high amount of elemental iron and has good bioavailability, but is associated with side effects and staining of teeth. Ferrous fumarate has a similar efficacy and GI tolerance to ferrous sulfate. Then we have ferrous ascorbate. It contains high proportion of elemental iron. It converts ferric to ferrous form, inhibits the formation of insoluble iron complexes, and inhibit the conversion of ferritin to hemosiderin, preventing iron overload. So it seems to be a better option when you are talking of oral iron. If you see this chart, ferrous fumarate 60, ferrous ascorbate has 100 milligram of elemental iron. Other formulation have less elemental iron. Of course, ferrous sulfate is 60 milligram elemental iron. So ferrous sulfate, ferrous fumarate, and ascorbate, you have to choose of all these. Cheapest is ferrous sulfate. Now, what about this is for mild anemia. When patient is a very mild anemia, you start with oral iron and try to improve her. Now, for moderate anemia also, for first level of treatment, usually we give this around 200 milligram of elemental iron with the 1 milligram of folic acid daily for 6 months. And now here the issue is whether you want to give oral iron or parenteral iron. So some recommends that you first start with oral iron, and if patient is not improving or patient is non-tolerant, patient compliance is poor, then you switch over to parenteral iron. Or some recommend that you straight away start with parenteral iron also. So here it is you have to assess the situation. Now follow-up is every 2 months for compliance of treatment during the antenatal follow-up, and you have to do the hemoglobin estimation and then try to see. Now, if there is no improvement, then you have to refer the patient to higher center, because parenteral therapy is needed and it has to be given only at first referral unit center or at the district hospital. Now, this is what I am emphasizing, that for so many years, India first line treatment for iron deficiency anemia in pregnancy has been oral iron. However, side effects of oral iron, poor adherence to the tablet ingestion, and low therapeutic impact are among the reasons for consideration of new standard for treatment of ID in pregnant women. And that is why the people are more and more now thinking that why not start with the parenteral iron. Now we have different parenteral iron: sodium ferric gluconate, iron destron. This we have all used, iron destron, but it is associated with anaphylactic reaction. So a test dose is required and it is given in IV drip. But now I think nobody is using IV destron because we have better parenteral iron formulation. And here we have this one. Iron sucrose. So I'm omitting iron destron, but now iron sucrose is being used many places. It has certain advantage over other preparation because no test dose is recommended, minimal side effects. It is usually not associated with anaphylactic reaction. Most preferred in patient undergoing hemodialysis because it has low molecular weight. Ensure that it is given in the hospital setting, and we have all the facilities to manage emergency situation. Because sometimes, because of the formulation, you may get some reaction in the patient. So it is advisable that your emergency kit should be ready. And total dose is calculated in divided dose and alternate days, not more than 200 milligram at a time. It is given slowly over 1 hour, and it is well tolerated and very safe. Hemoglobin rise is evident as early as 5 days. Now then ferric carbioxymaltose is that drug. Now I think all of us are using this. We are at least we have stopped using iron sucrose also. We are using ferric carbioxymaltose. It is intravenously administered ferric carbioxymaltose, which rapidly improves hemoglobin level. And if required, you can give another dose after 1 week, or you can start with oral ferrous sulfate, as we know, 60 milligram elemental iron 2 times or 3 times a day. In general, improvement in hemoglobin levels are more rapid with ferric carboxymaltose than ferric sulfate. And ferric carboxymaltose also replenishes depleted iron stores also. Now, this is the study from India. Dr. Sanjay Gupta has published this study on the clinical effect of carboxymaltose in Indian pregnant women. Earlier, there were apprehensions that whether carboxymaltose should be given in pregnant patient or not, because it has been started and recommended in postpartum patients only. But now a lot of evidence has come, and this is another study from India, that yes, it is safe and useful in pregnancy also. It can be given in pregnancy also. There's no restriction. So this was the study, another study on ferric carboxymaltose, which also highlighted that treatment with FCM resulted in rapid replenishment of iron stores in pregnant women with significantly higher HB rise over a 12-week period. Convenient dosing with lesser number of total doses to complete the treatment will lead to better compliance in community setting. So this is the study from AIIMS. So advantages are many. Larger dose in a single IV injection lead to increased bioavailability of iron and more rapid correction of iron deficiency anemia. To ensure iron sufficiency in the developing fetus, none of the newborns were diagnosed with iron deficiency anemia. It reduces the risk of poor adherence to the treatment. It is safe with no serious adverse event reported. It is more effective than oral iron in the treatment of iron deficiency anemia in pregnant women. Now, if you see this, there are some contraindication where lack of facilities for resuscitation, non-history of anaphylaxis. Early first trimester, we try to avoid iron therapy. And when there is a known state of iron overload in this situation also, we try to avoid giving iron therapy. And we know there are a lot of uses or indication when we can give parental iron therapy, when there is a failure to oral iron therapy, non-compliance or intolerance to oral iron, late second or third trimester with moderate, or when there is severe iron deficiency anemia, when there is a malabsorption, bleeding diathesis, when hemorrhage is likely to continue, right? And even you are giving erythropoietin also, in those situations, it is better to add on injectable parental iron. And in postpartum period also, it is better that you give one shot of parental intravenous iron, and then patient can go home and she's not worried about anything further, because you have provided enough iron to replenish her stores also. Now, this is another thing which has come in the market. I just want to highlight and touch this formulation. I don't want to go into the detail. This is a ferric pyrophosphate equivalent to elemental iron of 30 milligram. And if you see, this is a sucrosomal iron. It has the advantage that it is not effect on absorption or liposomal iron. There is no effect on absorption of either of these. They are metal irons, or these all phytates, tannins, calcium, milk, as Dr. Pai has highlighted. These all inhibits iron absorption. So this sucrosomal iron, when you give, there is no effect on the absorption of liposomal iron. And there is no increase in oxidative stress in the enterocytes also. So it is better absorbed and with no side effects, basically. So, and 30 milligram and all 30 milligram is available to the body for the correction of anemia. Then another is, this is also has been introduced in US. This is not in India, and it is useful in chronic kidney disease patients. And but comparative safety data and other IV iron formulation are lacking. This is ferromoxitol. But we have to have more evidence to understand this formulation. And if you see, as now when we know these are the formulation, we have oral formulation and we have injectable formulation. With oral formulation, you have to understand that when you give oral formulation, usually the patient have feeling of well-being, that yes, she is improving. Her general symptoms will improve in 3 to 5 days. She will have feeling of well-being. And after 5 days, you will see reticulocyte count has increased. So that is the earliest sign, and you have to check whether reticulocyte count has increased or not, whether it has improved or not, because that will tell you whether your iron therapy is working or not. Because hemoglobin will take longer time to rise. It will take around 3 weeks to show 1 milligram rise, right? So these are the earliest things to see that whether your therapy is working or not. And then if it is working, you will continue with your iron therapy, and slowly, her hemoglobin level will improve, that her stores will improve, and that way you work. If you feel there is any problem, a patient is not tolerating, patient is having problem, patient is having problem with the compliance. Basically, sometimes they say, no, we have to assess their socio-economical status also. Sometimes the patient is staying on 3rd floor and she has toilet only on the ground floor. And during pregnancy, in 2nd trimester or at the start of the 3rd trimester, she may not climb stairs 2-3 times or 4 times. So she avoid taking iron because she has the fear that by taking iron, she has to go to the toilet because of GI disturbance. So these are the problems which you have to take into consideration. So she will not take oral iron. So these are the issues which we have to consider. So when patient is not taking oral iron, there is a problem, there is a compliance issue, there is a side effect. So we can start with the parental iron. And I think inject IV iron is a better option now. So problem with the oral iron now, it is very easy to recommend and prescribe oral iron. The problem with the oral iron is that of our diet, our vegetarian diet, and there are a lot of inhibitors in the vegetarian diets, and phytates, tea and coffee, calcium, tannins, right? There's so many things. So why this oral therapy or why our iron therapy fails when there is an undetected blood loss, bleeding piles, hookworm infestation? So that is why now it is important, and now it is recommended in the government program that whenever you are starting iron therapy, you have to give antihelminth to the patient, right? So that is a must. Now, coexisting disease may also interfere with the response to the oral iron therapy, like if there is any infection, urinary tract infection, which interferes with erythropoiesis or kidney failure, some other dietary deficiency, blood loss. It is very important here also to understand that whenever we are talking of iron deficiency anemia and we are treating the patient with iron therapy, oral iron or parental iron, it is always it is important to give her folic acid and vitamin B12 also, because what we have observed that it is always a global deficiency of all the micronutrients on all these products, all these elements. It is not that patient will have enough B12 in the diet, but she have very low iron in her diet, or she has adequate folic acid but low iron, or only folic acid deficiency will be there, she will not have iron deficiency. So it is not that way. It is always a global deficiency. So we have to see to it that we give her all. If we give only iron, so sometimes what happens, there is unmasking of B12 deficiency. So patient will not improve, rather she will manifest her B12 deficiency. You are giving iron and patient is not improving. So these are the situations which sometimes happen. So one has to be careful that you give and supplement all like B12, folic acid and iron. Sometimes patient has blood loss, continue to have blood loss, so patient will not improve. Now these are the problems that we have to be careful when we talk of oral iron therapy. The pulses, cereal, jaggery, beetroot, green leafy vegetable, meat, liver, egg, fish, legumes, dry beans, and iron-rich white breads are the rich source. But if it is taken with food, there is some reduction in side effects related to the GI tract. So this sometimes we advise a patient may take oral tablets after meals. But the problem is that our Indian diet consists of cereal, and cereal contain phytic acid. And these phytates reduce iron absorption. But addition of vitamin C in medicine or in diet enhances iron absorption. Now, the food intake should be especially rich in protein, iron, and other essential micronutrients. We have to tell her about locally available food rich in iron, such as groundnuts and jaggery. We have to tell the woman to avoid taking tobacco, tea, coffee, or milk, especially within 1 hour of a meal, as they have been shown to interfere with absorption of iron. We have to advise her to take food rich in proteins and vitamin C, like lemon, amla, guava, oranges, as they both help in absorption of the iron. The diet should be rich in fiber so that she does not have constipation. And diet should be advised keeping in mind the socioeconomic condition, food habit, and taste of the individual. We should counsel the patient accordingly. And these are the different charts available. There are a lot of many, see, green leafy vegetable and all these are the rich source of iron. These are the other, like if you see the plant foods rich in iron, broccoli, pumpkin seeds, papaya, figs, sprouts, hemp seeds, avocado, bananas, almonds, grapes, tomatoes. There's so many. Spinach, green peas. See, these are all rich in iron. Then we have beans, soya beans, lentils, chickpeas, and all these are grains, and nuts and seeds. These are fruits, and these are all different varieties of items which are rich in iron. So we have to advise, we have to show them this chart, or we have to counsel them that yes, These are the locally available things which they can use. These are the simple charts. If you see iron and healthy foods, we can put all these charts in our clinic or in our wards so that patient learn about iron-rich food very easily. Say fish, seafood, spinach, broccoli, pumpkin seed, green peas, apricots, almonds, raisins, meat. So all these things are very easily available also locally. Beans, lentils, kidney beans, chickpeas, peanuts. All these are the source of iron. They support your iron stores and prevent anemia. These are the things which are highlighted. This is another chart. Like this adds legumes, beans, lentil, eggs, meat, leafy green vegetable, nuts. It also highlights the eat citrus foods and avoid coffee and tea during your meals. This is by WHO. So these are the different charts which are available. We have to use all these. Now, few more tips, counseling tips to the women. We have to highlight that they should not be advised to take any medication unless prescribed by your obstetrician. Though the tablet should be taken preferably in the morning on an empty stomach, she may take the tablet with meals or at night. This will help avoid nausea. She should avoid taking the tablet with tea, coffee, or milk as they reduce the absorption of iron. Tablets containing calcium should not be taken at the same time as iron tablets, as the absorption of iron is reduced in the presence of calcium. The woman should be advised to sleep for 8 hours at night and rest for another 2 hours a day. She should be advised to refrain from doing heavy work. These are all important counseling tips which we have to give it to the lady. Now, the next part is, which I will take a few minutes more, about the blood transfusion in anemia. Now, blood transfusion is, you should understand that it does not treat anemia. It will not treat the cause of anemia. It will not correct the non-hematological effects of iron deficiency anemia. So when to give blood? Now, less than 36 weeks, hemoglobin 5 gram. So be divided into as per the period gestation. Now, when hemoglobin is less than 5 gram, or when it is between 5 to 7 gram with established or evidence of cardiac failure or clinical evidence of hypoxemia, pneumonia, or any other infection and malaria. So in these situations, one should go for blood transfusion. When the pregnancy is 36 weeks or more, one should try to give blood transfusion because you are afraid that patient may go in labor anytime. So when the patient goes in labor for vaginal delivery, her hemoglobin should be at least more than 8 gram. So that is our target. So we should try to see our window, whether we have enough time to improve her hemoglobin by our parental or oral iron or not. If not, then it is better to improve her hemoglobin, to put it in the safe limit by giving blood transfusion. It is also important to understand that the corrected anemia, if patient has reached the safe level of anemia during pregnancy, then the morbidity and mortality associated with the condition are very, very less as compared to the patient who is anemic. So this we have to understand, and we have to try to improve the anemia as early as possible by adequate means. Now, when elective cesarean is planned, there is a history of APH, or there is a risk for postpartum hemorrhage, or there is a patient with previous section. If hemoglobin is less than 8 gram, it is better to arrange 2 units of blood, and if it is 8 to 10 milligram, it is better to arrange 1 unit of blood transfusion. Now, sometimes we have to give erythropoietin also to treat iron deficiency anemia. It is a glycoprotein produced by kidneys in hypoxic condition, and it stimulates the bone marrow to produce more erythrocytes. Erythropoietin injection along with injectable iron can raise the hemoglobin more quickly than the injectable iron alone, up to 3 grams per deciliter in 2 weeks, and it decreases the need of blood transfusion. Now, it can be given, it is the advantage that it is a rapid correction of severe anemia in less than 2 weeks. So it is useful or indicated when anemia is not responding to intravenous iron alone, and when treatment of severe iron deficiency anemia as an alternative to blood transfusion. So these are the 2 indications where you can give erythropoietin and it is a recombinant erythropoietin. And these are the doses, and it improves hemoglobin by 3 grams in 2 weeks' time. So I think with this, I just stop here. This is the flow chart which has shown how to plan the management of iron deficiency anemia. And you have to see according to the level of anemia, and you have to decide whether you want to give oral iron, or you have to give parenteral iron, or you have to give blood transfusion. Now, one more slide I want to show you about the anemia, what to do in the labor. So women who are still anemic at the time of delivery may require additional precaution for delivery, including that these patients should deliver in hospital setup because they are at risk for antepartum hemorrhage and the postpartum hemorrhage. And we have to have IV access. As soon as these patients enter labor room, IV line should have been established. Although we will not give IV fluids, but IV access should be established, because if you give IV fluids, there is a risk of volume overload. We have to make arrangement for adequate cross-match blood, because these patients are at risk for losing blood. So we have to have active management of third stage of labor, and oxygen and other measures to deal with heart failure and PPH to be kept ready, and LSCs to be done only for obstetric indications. And in the postpartum, once they have delivered, in the postpartum period, as I told in the initial phase, that we have to give iron and folic acid for at least 6 months, or we can give postpartum IV iron therapy, also peroxycarbimol throws 1 injection, and then patient can be sent home, because we are happy, we are satisfied that we have corrected her anemia and we have replenished her store also. So with these words, I stop here. Thank you very much.
Thank you, sir, for excellent practical tips you have given. I see only Amrita ma'am. I think Dr. Desai couldn't join, so I request Madam only to conclude and
yes, it was indeed a very good talk by Dr. Ashok Kumar. He has covered the wide spectrum, right from the oral as well as the parenteral, and he has really stressed about the new molecule also, about the ferric intravenous ferric carboxymaltose and ferric pyrophosphate. At the same time, he has really insisted for the routine thing. Usually we miss, like by giving the hookworm infection. And it was a very nice talk and very nice presentation with the carry home crisp message. Thank you, Dr. Ashok Kumar, and thank you, Dr. Archana.
Thank you, Amrita ma'am. Thank you, Ashok sir, for this excellent talk. I would move the baton forward, inviting Dr. Munjal Pandya, and a young talented boy who is doing such a great work. And you can see his CV. He was a Honorable Secretary of Ahmedabad Obstetric and Gynec Society last year. Received Shrish Daksari Young Talent Award from AOGS year 2017-18. He also co-edited a book on male infertility in January 2019. FICOG Diploma in Minimal Invasive Surgery. And he's currently Associate Professor, Narendra Modi Medical College, Ahmedabad, Gujarat. Has published many papers and chapters, authored the Gujarati photo book. I have read it. It's excellent. And hobbies are painting, guitar, singing, writing, tennis. And you can visit Facebook and see his excellent gear photography as of now. Love your angles to take the pic. Munjal, over to you for conducting the program further.
Thank you so much, madam. Thank you so much, madam, for kind words. Am I audible, ma'am? Am I audible? Yes.
Yes.
Thank you so much.
Yes.
Yes. So now we would move forward to session 3 of today's webinar. The topic is cardiac problems during pregnancy, the challenging or changing trends. I would like to invite all the 3 chairpersons for the session. Dr. Anita Shah, madam, can we have the CV, please? Madam is MD DGO FIMS, practicing gynecologist in Surat since 1988. President of SOGS for the years 2000 and 2001, when SOGS received Best Society's trophy from Foxy. Organizing chairperson of the World Conference on Population Sterilization, February 2003. Organizing secretary of National Conference of Indian Menopause Society in 2009 in Surat. President of Udhna Medical Association 2002 and 3. Organizing secretary of State Conference of Gujarat Sogog 1998 and 2018. We welcome you.
No need to describe all the things. Yeah.
Can we have next CV, please? Dr. Jinesh Rathod. Yes. He's a good friend of mine. We did residency in the same year. He did from NHL and I did from LG. He is MS OBGY from NHL, a USD training from BS. He has been panel surgeon for performing laparoscopic tubal ligation. Thank you so much. And he is actually, again, a humble person and down. Next CV, please. Dr. Jagruti Desai, madam, again, a versatile person, I would say. Madam has done Upantya Visharad and Visharad as well for classical singing. She might not have mentioned that in her CV, but her whole family is into classical music and expert they are actually. So she is doing private practice at Udna Hospital since 1985, visiting consultant at Nirmal Private Hospital.
Yeah, thank you, Dr. Mujan. It's all right.
And we welcome all of you, and we would like to have introduction of a speaker from any of you. Thank you. Thank you so much, ma'am.
Should I do? Yeah. First of all, thank you very much, Dr. Archana, Kirtan and Munjal for inviting us over here as for this very interesting webinar. As such, Dr. Sneha Bhuyer is known to everyone. She is a very active, dynamic, enthusiastic lady of our Foxy and practicing since more than 25 years. She has received a lot many awards. She is holding a lot many posts in Foxy and AOMS and AICOG and everything.
Thank you. Thank you, madam. Thank you so much.
The most important thing is she's contesting for the Vice President Foxy. And the election will be, I'm sure, finished by, I think, 10th of August. And in Surat, we are organizing. Yeah, in Surat, we are organizing zonal conference of Indian Menopause Society on 12th and 13th of August. So, Sneha, we would like to celebrate your VP elections victory in Surat.
Yes.
All the very best. And for today's webinar, I am sure that you will rock by describing and giving a lucid talk, and everyone will enjoy with a lot many carry-on messages. Thank you.
Thank you so much, dear Dr. Anita. Thank you. A very good evening to all of you, and I welcome all the presidents. I can see Dr. Amita Shah and so many, Dr. Mahendra Soni, Dr. Paresh Patel, and of course our chairperson for this session, Dr. Jagruti Desai. I can see my dear friend, Dr. Girija Wagh, who is an excellent academician. And of course, you're going to have enlightening on the subject by her. So I just take this opportunity to share my screen, and I need to be really quick on the subject because I think we have two more speakers waiting here. So I just start my presentation and just go to the first slide. And because this is, I'm sure medical disorders, you all have, know the theoretical aspect is so quite boring, and I'm just trying to make this a little interesting. This is cardiac problems during pregnancy, such a grave picture. So what are the changing trends? When I was a kid, the heart looked like this, I thought, but when I grew up, the teacher drew this diagram. So is that the change? Friends, jokes apart, I just take you through this subject. The heart disease during pregnancy, though becoming quite uncommon nowadays, it still complicates almost 1% of all pregnancies. And all of you know that the physiological changes which occur during pregnancy, not only in the cardiovascular system, but all the systems of the body. And these changes mimic that of the heart disease. And if this woman has a pre-existing heart disease, this will definitely complicate the pregnancy and will affect the maternal as well as the fetal prognosis. So what are these physiological changes and when do they start? They start by 6 weeks of pregnancy, and they reach at its peak by 32 weeks of pregnancy, continued throughout the pregnancy, during labor and delivery, and 2 weeks postpartum. how do they affect the prognosis of the fetus as well as mother? For fetus, there is a chance for spontaneous abortion, preterm labor, that is prematurity for the baby, fetal growth restriction, intrauterine death may happen. And of course, almost 5% of these feti, the babies, they are born with congenital heart disease. For the mother, all of you can understand cardiac failure, bacterial endocarditis, pulmonary edema, and embolism, and of course, polyhydramnios, preterm labor, and PPH. So there is a increase in the blood volume by almost 20 to 40%, and that reaches the peak by 32 weeks. All of you know this. So because of this, there is an increased load on the heart, increased preload. But because of the vena cava compression, there is stresses in the lower limbs and the pelvic vessels, and there is decrease afterload because of this. So the stroke volume is increased by 23%, the cardiac output is increased by 43%, and the heart runs faster by almost 10 to 15%, 10 to 15 beats per minute. The blood pressure rise is around 5 to 10 millimeter of mercury systolic. Blood pressure drops down by 5 to 10 millimeter of mercury systolic and 10 to 15 millimeter of mercury diastolic. This, of course, you know, because of the vasodilatation, relaxation of the smooth muscle. This lady is more prone for varicosities, the lower limb. The reason being vena cava compression, relaxation of the smooth muscle leading to increased capacitance, and of course the increased blood volume as well. So to sum up, we have the plasma volume going up by 40%, cardiac output is higher by 43%, heart rate more by 17, mean arterial pressure is more by 4, and the stroke volume rises by 27. The systemic vascular resistance goes down by 21%, and the pulmonary vascular resistance goes down by 34. So because of all these changes, the lady may experience easy fatigability, shortness of breath, decreased exercise tolerance, and palpitations. So occasionally she may have peripheral edema, the distended jugular veins, and of course she may just hear what you label it as the breast blue. And this is explained by the physiological changes that happen. So the physiological changes mimic that of the organic heart disease. Then how do we differentiate each other? So how do we differentiate the physiological changes from the organic heart disease? Of course, careful history taking, detailed clinical examination, and investigations. The symptoms of physiological changes, they are usually mild, easy fatigability, maybe tachycardia, split heart sound, and the apex is deviated slightly to the left and upward, and the systolic murmur. But when you have the organic heart disease, the patient experiences progressive dyspnea, orthopnea, paroxysmal nocturnal dyspnea, chest pain, and nocturnal cough or hemoptysis. When you examine cyanosis, clubbing of the fingers, persistently distended neck veins, and systolic murmur of grade more than 3/6, diastolic murmur, persistently split, second heart sound, and of course cardiomegaly. And you have the investigations to support your diagnosis, right from complete blood count and the enzyme studies, troponin 1 and CPK. And when you do the ECG, maybe the arrhythmias, the axis deviation, hypertrophy, echocardiography showing you the cardiac status and structural anomalies, X-ray test showing you the cardiac size as well as outline. And then, of course, you may have specific investigation for specific diagnosis. So once we diagnose this woman having a pre-existing morbidity as heart disease, then we have to categorize her according to the etiological classification, which can be congenital or acquired. And in congenital, you can have acyanotic and cyanotic. So in non-cyanotic, you have ASD, VSD, PDA, and of course, cyanosis, you have the palostatrology, Eisenmenger syndrome. Rheumatic heart disease once was very common. I'm sure the obstetrician who are there here, maybe down the line, 3 decades earlier, we used to have many cases of pregnancy with rheumatic heart disease. Peripartum cardiomyopathy, which is coming up very fast, ischemic heart disease, and other problems as well. So etiological classification, Once you diagnose the patient, then you classify or grade her according to the limitation of physical activity. That is in New York Heart Association classification. Grade 1, you have no limitation of the physical activity. Grade 2, you have mild limitation. Grade 3, you have marked limitation of the physical activity. The patient cannot even perform activity, little activity. She's only comfortable at rest. And grade 4 is even she's breathless or symptomatic at rest as well. So classification according to the severity. And why this is important? Because if you have high risk patients like pulmonary hypertension, Eisenmenger syndrome, aortic coarctation with valvular involvement and Marfan's, then you should advise the woman not to conceive. So low risk and medium risk. Why it is important? If at all you diagnose this lady before pregnancy, you have to optimize her cardiac status. So rheumatic heart disease is becoming quite uncommon nowadays, and that is because of the early diagnosis, effective management with the help of antibiotics, and the progression of the disease is stopped at the level of just rheumatic fever, and it is not allowed to progress beyond the migrating polyarthritis or pancreatitis. So this is what the result was, stenosis or regurg. Now, the congenital heart diseases are becoming more and more common. So from this, the acyanotic or non-cyanotic heart disease, they are common, and they are, they are already presenting late in their life, maybe sometimes around in their 40s. So why this is so? Because here you have the left to right shunt. But once the pulmonary vascular resistance increases to such an extent that the pulmonary hypertension takes place and there is a reversal of shunt. So this leads to the cyanotic heart disease, now what is called it as Eisenmengerization. And this is what just the picture to show this is a normal heart, and this is the heart which is showing the atrial septal defect, and this is the normal heart, and this is the heart showing the ventricular septal defect, and this is the PDA. These are just some of the pictures showing the regurgitation. Now coming to the cyanotic heart diseases. I'm sure the obstetricians from our generation, they have seen this spherostatrology as congenital heart disease with VSD, right ventricular hypertrophy, pulmonary stenosis, and overriding of aorta. So these patients used to previously succumb during their childhood or early adolescence, and they were not reaching the childbearing age. But because of the successful corrective surgery, now they are reaching the they're reaching this childbearing age, and we're getting many patients to manage as well. So rheumatic heart disease, ischemic heart disease, and PPCM, these are the common ones nowadays. Though for developing countries, the rheumatic heart disease is becoming very uncommon. Coming to coarctation of aorta, coarctation, that is narrowing, and this is usually at the level of the aortic arch. But when it involves the valve, it becomes a very high risk, that is grade 3 severity. And for this, we should not, the obstetrician should not allow this lady to become pregnant. Marfan's syndrome is actually a genetic syndrome. It's a soft tissue disorder. You have the tall, long lady with disproportionate upper and lower air segments, and the extremities. You have hyperflexible joints. And this lady, usually they have mitral valve prolapse and aortic aneurysm. So when this coronary artery disease, which is becoming quite common nowadays because of the changing demography of the obstetric population. Usually the patients we are getting now age more than 35 years, obesity, unhealthy eating habits, sedentary lifestyle, increased stress, and smoking and drinking habits. So all these women, they are more prone for coronary artery disease, ischemic heart disease, and of course the myocardial infarction may complicate the pregnancy. This is just a picture showing you the lipid deposits of the in the plaque in the coronary artery disease. So apart from the medical management, the counseling definitely plays an important role. The evidence says that smoking and alcohol both are hazardous to mother. But look at this picture. Can baby off the bottle? Can we really advise this way? We can't be so judgmental. But if not, she can't stop completely. We can guide them to at least we can guide them to reduce on it and try to do justice with the pregnancy as well. So obesity, you have to optimize the weight, treat the diabetes and maintain the euglycemia. Hypertension should be treated. Smoking, of course, should be stopped. And these ladies, we shouldn't wait for, the chest pain or vomiting and breathlessness. We should be able to diagnose them at an earlier stage when they have exercise intolerance, maybe just tachycardia. If at all you face this, I'm not going to cover in details the cardiac management because our topic is mainly the changing trends of presentation of the cardiac diseases. So if at all you face this emergency, immediately call for help, propped up position, left lateral position, oxygenation, fluid restriction, and meanwhile, ECG, 2D echo, coagulation and lipid profile, enzyme studies should be done simultaneously when you are doing the continuous cardiac monitoring. The cardiologist has to be called for help at the earliest by the time give her analgesics and of course the full role of diuretic, but we have to ship the patient to ICU as soon as possible. And once she is managed with the emergency, then of course the role for counseling in the form of diet modification, active physical exercise, change of lifestyle should be advised. Now, should we wait for this catastrophe to happen, or should we have premarital or preconception counseling for all these conditions? Definitely, when we examine the patient and we label her as having heart disease, if it is a grade 3 heart disease, grade 3 severity, then of course she should not conceive. And if at all she conceives, she has to undergo MTP during first trimester itself. The maternal mortality actually varies directly with the functional classification at the onset of pregnancy. And that's a reason we have to optimize her cardiac status before allowing her to become pregnant. Whatever medical or surgical treatment is necessary, we can give her. I've already said that if at all this high-risk lady conceives, then we have to go for early pregnancy termination, not even late pregnancy. That itself is associated with higher mortality rate. ANC care, definitely it has to be very frequent and not like monthly, like routine ANC. And every visit you have to be really vigilant on the clinical examination. You have to re-evaluate the functional grading of this disease at every visit. Ensure the treatment compliance, and at the beginning only we have to tell her, explain the need for frequent visits, evaluations, and the need for delivery at the tertiary care center. We have to talk to her about the prognosis of the pregnancy and maternal and fetal outcome. So this is just the list saying what you have to advise the patient: adequate rest, diet, iron, vitamins, iron and vitamins. Regularly, the hygiene has to be maintained very properly. There should be no endogenous infection to avoid bacterial endocarditis. The dietary salt restriction is very important. Avoid smoking and alcohol. Avoid drugs which cause increase in heart rate. So you have to go for benzathine penicillin to prevent the recurrence of rheumatic fever if it is so. And then diuretics, beta blockers, digitalized and anticoagulant. Surgical treatment, if applicable, balloon mitral valvulotomy has to be done. About smoking, I have already talked that smoking is definitely hazardous to mother as well as baby, and the blood pressure has to be, under control. The diet should be very good. It should be even for reducing the weight, she should not skip any meal. Instead, we have to divide her meals, caloric intake. We have to choose the spread widely, maximum of proteins and less of carbohydrate, that to complex carbohydrates, vitamins, minerals. She has to drink lots of water, eat fresh fruits and vegetables, minimally processed food, and she has to control her cholesterol Stress has, it can worsen diabetes as well as hypertension. It can increase your cholesterol. So you have to really relax mentally and physically. Optimize your blood sugar level before pregnancy. If at all during pregnancy, you have to control. Moderate exercise of half an hour daily, maybe just 5 days a week should suffice. That should be under supervision, provided there is no contraindication. And then when you're continuing this pregnancy, when do they need admission and any intervention? So if you have a patient who is NYHA class 1, that is, she doesn't have much of a limitation and symptoms, then you can just advise her to get admitted 2 weeks before her due date. Class 2, 28 to 30 weeks is the time where you have to really hospitalize and keep her under observation. But anytime you find that NYHA class 3 and 4, you have to, the moment you diagnose this patient needs hospitalization. Wherever you have anticoagulants to be changed during early pregnancy at 36 weeks, there you need the admission. And then when you need the endocarditis prophylaxis, sometimes you have the failure. So in these conditions, you have to hospitalize this lady up. We have already talked about endocarditis prophylaxis. These are the drugs which I'm not going to go into the details. Labor management, only for institutional delivery, we have already said, but in tertiary care center, induction of labor, there's no role for induction of labor because it's a heart disease. It has to be done only for obstetric indication. Oxytocin, which is concentrated infusion, is preferred, and of course, intracervical Foley's catheter or maybe the PG2 gel should be preferred. How do you manage it during first stage of labor? The patient needs to be confined to bed, propped up or semi-recumbent, preferably left lateral position. She has to have oxygen inhalation. She should not have pain. Maybe analgesic should be given. Epidural analgesia is preferred here. IV fluid should be restricted and stop anticoagulants. The moment you suspect that she's going into labor, the anticoagulant should be stopped. If she is likely to go into failure, then you have to give digitalize. If there is any bronchospasm, deriphyllin or aminophylline, and of course diuretics if you have congestion. Cardiac monitoring and the entire multi-para monitoring has to be done, and the patient has to be evaluated by anesthetist and cardiologist during labor. Second stage, you should not allow her to, suffer lots of pain. She should not bear down for a longer period. You have to cut short the second stage of labor. To avoid PPH, maybe we give ergometrin, but this is not a patient. You have to just give 10 units oxytocin, concentrated either bolus or concentrated infusion, and the rest of the things continue. Avoid bolus, syntocinon, and ergometrin. That is what the message is. But this is not the end of the story. The first hour after delivery is a period where she is more likely to go into failure, and that is why you have to be really very vigilant, keep a watch on pulmonary edema, continue the same treatment and monitoring. Last point to be made is indication for LSCS. It is not per se for the heart disease. Otherwise, except the coarctation of aorta, maybe where you have the aortic aneurysm sometimes, where there is a fear of rupture. Peripartum cardiomyopathy is one more emerging condition where you feel, the patient just complains of weakness, fatigue, breathless, and you take it very lightly, and suddenly you find the patient worsens. So this is a condition where various things, hypotheses have been quoted, but the patient obese, patient mild hypertension, these are the common reasons, but high levels of prolactin and SFLT are supposed to play some role. There are various studies, but nothing has been proved till then. You have to just give supportive treatment to this patient. One of the investigations, they say that raised levels of brain natriuretic peptide is said to be diagnosis. Early recognition and supportive management is the key to success of this management. And of course, you have to advise this lady for again keeping a watch on all these excessive physical or mental stress, avoid infection. She should not have even postpartum anemia, and cardiological consultation for definite management of the heart disease should be done. Contraception, as you all know, absolute no to hormonal contraception, OC pills especially, and intrauterine contraceptive device is said to be nowadays MEC2. COC is a contraindication. Sterilization permanent if fetal vasectomy should be advised. So I would just end by saying that the incidence of rheumatic heart disease is decreasing overall. It is absolutely negligible in the developing countries, but in the developed countries, but in developing countries still cases are there. Though the congenital heart diseases with corrective surgery, ischemic heart disease, postpartum cardiomyopathies, and hypertensive heart disease are emerging very fast. So if you have the proper knowledge and implementation is done, prompt recognition and appropriate management is done, this gray picture can be converted into this rosy picture. And we obstetricians have a great role to play. We have to auscultate each and every woman who comes to you for your advice. If suspected, get evaluated and confirm the diagnosis. Do be very, vigilant in the monitoring, and then just manage this lady effectively throughout her pregnancy, delivery, and you'll send through. So thank you so much once again. And I take this opportunity to seek your blessings and your wholehearted support for my candidature as Vice President Foxy. And you have 2 posts here in the West Zone. I request one of the 2, most valuable, precious votes for me. The elections are from 1st to 10th August. And I just thank you in advance. Thank you so much. Any comments, any question I would like to, I'll be very happy to answer. Thank you.
So these were the very wonderful talk, excellent presentation with excellent slides. Your slides, on the contrary, of a woman. And
is it my network problem, Dr. Archana? Or
ma'am is having ma'am, you can conclude the session because we cannot hear Jagruti ma'am properly. Nita ma'am, are you there? She's there. So madam can give the concluding remarks. Jagruti ma'am has lost the network, I think.
Thank you very much, dear Dr. Sneha. It was really a very wonderful and lucid talk. You have covered the whole topic in such a nice way that in prenatal patients, during antenatal period, during pregnancy, and at the time of delivery and postpartum stage also, how we have to take care and how we should do, what we should do so that we can keep the mother and baby both the healthy. So I don't want to waste much time because another speaker is also there.
Yes.
So again, thanks a lot for covering the topic in such a nice way. Thank you.
Thank you so much. Thank you so much, Chairperson, Dr. Jagruti and Dr. Anita. Thank you so much. Over to you, Dr.
We now move forward with another yet important topic. I would like to invite Dr. Vinesh Nakum and Dr. Paresh Patel sir to chair the session for the same. Dr. Vinesh Nakum is a gynecologist, Anand Prasutigre, Halol. Welcome, sir. And Dr. Paresh Patel is here from the starting of the webinar. Welcome you, sir. He is from Disha, fertility expert at Khushi Fertility Center, and has done many IUI cycles and in-house IUI laboratories also there. He has passed from BJMC and past president Palanpur of OB Society and regular training batches for IUI also. So over to you, sir, to start the next session. Dr. Paresh, sir. You can introduce Dr. Girija now.
I don't have any this. Dr. Nakum is to introduce.
I cannot see him, sir. I think Girija ma'am is a very well-known faculty, so I think if we invite her directly for the talk also, she's a vice president and India chapter gestosis, member of governing council ICOG, and always a very pleasing personality with a sharp mind. So the educative lectures from her is always a rewarding situation for all of us. We learn a lot whenever she speaks. Over to you, ma'am, for the topic for today.
Thank you so much, Archana, for that quick, solution to the problem. And thank you for hosting this so very wonderfully. I can see I've been attending this meeting for some time now, and I can see how well it has been organized. And congratulations, Neha. You always make me very, very proud every time that I share the screen with you. And with due respects to my chairpersons, Dr. Vinesh Nakum and Dr. Paresh Patel, I speak to you quickly about thyroid dysfunction during pregnancy, because we have another eminent speaker following me and we should not deprive the audience of his wisdom vignettes. So in this particular lecture, we are going to try to find out what is the impact of thyroid disorders in pregnancy. How do you diagnose it? Does it really change anything in the pregnancy? What are the reference range and what is the best way in which we can manage it? I'm going to choose some case vignettes to help us understand this better. So we can see that this is 30-year-old SMC who's married for 4 years and trying to conceive, and everything was found fine except for the fact that her TSH was 4.5 and her prolactin was 19.3. I think we'll give credence to her prolactin, but TSH 4.5, the question comes, how do we proceed? We have to remember that infertility also is sometimes attributed to hypothyroidism, and before we get into any kind of understanding, we have to understand the thyroid physiological changes which occur in the pregnancy. We all know that because of the estrogenic stimulation which comes from the placenta, there is an increase in the formation of the TBG synthesis. And the test results that change in pregnancy are influenced by changes in this particular TBG concentration. And alongside, the plasma iodide levels decrease due to fetal iodide use and increased maternal clearance. And this leads to a notable increase in gland size in about 15% of pregnant women, and they may not have abnormal TFTs. So these things have to be remembered because HCG also simulates its action in the form of a TSH hormone. And this entire conglomerate gives us as clinicians a challenge to investigate it correctly. The fetal thyroid begins concentrating iodine at 10 to 12 weeks and is controlled by pituitary TSH by approximately 20 weeks of gestation. So whenever we are looking at the physiological changes in the thyroid function during pregnancy, we have to understand that during the normal pregnancy, the T4, T3, and the RT34, if you have decided to do the uptake test, they will decrease while T4, T3 will increase. In hyperthyroidism, the TSH will decrease while the rest of them would increase. T3 may not have any change. And in hypothyroidism, there'll be increase in the TSH while rest of all the parameters would reduce. So whenever we are looking at a thyroid dysfunction, it's always smarter to measure the TSH levels in the early pregnancy. And if it is found to be more than 2.5 milli-international units per liter, then you must go ahead and measure the T4 levels. And the TSH level, if they are undetectable, then that's a completely different ball game. You have to send the patient to the endocrinologist. If the levels are lower than reference range but still detectable, repeat in 4 weeks. And if it's still undetectable, again, she goes to the endo. TSH level between 2.5 and 10 milli-international units, you can check the TPO antibody status, and if they are positive, and if the TSH levels is more than 4 milliunits liter, treat with levothyroxine. If the levels are between 2.5 to 4, consider treatment with levothyroxine, also because it's positive for TPO. And if the TPO antibodies are negative, then only the levels which are more than 4, you may consider treating. If you have a TSH level more than 10 and low free T4 levels, check the antibiotic status, and we have to confirm the cause as to why this woman has autoimmune hypothyroidism. And in these patients also, you would commence with levothyroxine and definitely take the endocrinologist on board. So many a times this particular window is something which is amenable to a gynecologist practice, but rest of the extremes have to be taken to the endocrinologist. Now, infertility can result from interplay between the HPT and the HPO axes because there can be impaired LH response to GnRH stimuli, high TRH, hyperprolactinemia, increased ovarian volume, increased stromal depots, increased TSH, pseudo-feedback inhibition of FSH-LH, reduction in the SHBG pool, and therefore the androgen clearance is reduced, and therefore there can be ovulatory disturbance. And this increase in ovarian volume and stromal depots and all the rest of the hormonal profile may confuse our diagnosis with PCOS, and one has to be very careful not in labeling these patients as PCOS, but identifying that probably they are hypothyroid. So the Indian Thyroid Society and the FOXY 2019 recommendations talk of evaluation of serum TSH concentration for all women seeking care for infertility. L-troxin is recommended for infertile women with overt hypothyroidism, and it may be considered in subclinical hypothyroidism women who are attempting natural conception given its potential benefits in comparison to its minimal risk. And further, subclinical hypothyroidism women undergoing IVF or ICSI should be treated with levothyroxine, and the goal of treatment is to maintain the TSH concentration of less than 2.5 milli-international units per liter. Should the TPO antibodies be tested? L-troxin may be considered in euthyroid, but thyroid antibody positive women who are undergoing ART, and given its potential benefits in comparison to its minimal risk. And I think this is a repetition of the slide. And so therefore, in conclusion, for our first case vignette, when the history of infertility, do test for thyroid profile, TPO antibody only if history or blood test suggests TPO positive, but euthyroid, give thyroxine. Subclinical hypothyroidism 2 must be treated and always keep less than 2.5 levels. So this patient, with your tender loving care, conceived and became case number 2. And now she's come to you with 6 weeks of pregnancy, and she's come to you in the first ANC very jubilant and happy. So what investigations would you do for this patient is the question that we have. Routine or high-risk screening? Because we all have to look at risk factors such as age, family history, and then whether she has goiter, whether she has antibodies positive, whether she is symptomatic, whether she has pre-diabetic or diabetic, has history of miscarriages, preterm births, any autoimmune disorders, any history of any surgery, morbid obesity. All these have to be taken into consideration, and then accordingly you have to program of position her screening. Meta-analysis has shown that case-based screening can miss up to 49% of pregnant women with thyroid dysfunction, and therefore all pregnant women should be screened at the first antenatal visit, at least by measuring the TSH level. And it has been found that it's better to do a universal testing. It's cost-effective, would definitely improve the maternal and fetal outcomes, always try to prevent the preventable, and the advantage of treating borderline biochemical abnormalities, however, is questionable. So in second situation, you would conclude that the serum TSH should be done at the first visit, designate the mom either euthyroid, hypo or hyper, and rule out other risk factors. Now, Mrs. SMC has now reached 18 weeks of gestation. How will you monitor her antenatal period and what complications can occur? So maternal complications can be anemia or cardiomyopathy, preeclampsia, placental abnormalities, low birth weight infants, PPH, and myopathy. Cognitive impairment is a possibility in the babies, neurological abnormalities, developmental and congenital hypothyroidism. And neonatal, they are at risk of hyperbilirubinemia and respiratory distress. So if you have increased TSH and lowered FT4 outside the trimester-specific reference range, or you can look at trimester-wise, 0.8 to 1.53 in the first trimester FT4, 0.7 to 1.2 second and the third trimester. Look for TSH-secreting pituitary tumors, thyroid hormone resistance, or central hypothyroidism with biologically inactive TSH may be considered, and adequately treat the hypothyroidism. No extra maternal or fetal testing is essential. Levothyroxine is sufficient dosage, adjusted every 4 weeks until return to normal. And Graves' disease sometimes is a possibility. I currently have 2 such patients who have undergone ablation, surgical resection. And in that case, you will have to get her under trap monitoring along with an endocrinological support system. So when you are managing overt hypothyroidism during pregnancy, more than 2.5 should be treated. Dose of levothyroxine to be 1.6 to 2 micrograms per kg per day, calculated correctly and delivered to the patient. Maintain the target TSH of less than 2.5. And patients who have pre-existing hypothyroidism, the thyroxine dose should be increased by 30% as soon as the pregnancy is diagnosed. Regularly, TSH monitoring to be undertaken 4 to 6 weeks until mid-gestation, and at least once near 28 weeks should be done. Now, rising HCG has inverse relationships with serum TSH, and therefore TSH should be kept less than 2.5 in the first trimester, less than 3 in the second and the third, and should be monitored 4 weekly till stable level is achieved. So this is the message for our third case. And I would like to share one more experience of a patient with Hashimoto's disease. We had a history of previous loss at 19 weeks. Then she came to us at 13 weeks with missed abortion. And at around the second loss, I diagnosed her to have thyroiditis. And then we had given her preconceptional counseling, stabilization, low-dose aspirin, insulin sensitizers, bacterial vaginosis prophylaxis. Still, she reported at 23 weeks with an open cervical canal. You can appreciate it here. The distal one is closed here. And this is how we took her then for, some relaxation and a rescue and cerclage. And you can see the picture here after 1 week. And we could salvage her till about 36 weeks of gestation, where she had to be delivered because she went into prom and it was a breech presentation, and we took her for an elective C-section. So coming to case 4 is a known hypothyroid on regular treatment, has had 2 miscarriages. And how would you now proceed with her? She's taking thyroxine 50 mcg. We have to remember that 18% of all pregnant women have TPO antibodies and TGAB antibodies positive. Adverse effect on the pregnancy and the developing fetus is a possibility. Separately increase the risk of thyroid dysfunction following delivery and during the postpartum period. And euthyroid women who are TPO antibody or TG antibody positive should have measurement of serum TSH performed at time of pregnancy confirmation and every 4 weeks. Now, we do not know whether there are any significant differences in preterm births or whether they are responsible for causing miscarriages, but significantly lower rate of preterm delivery in LT4 treated women compared with those who received no treatment has been observed. And in women with subclinical hypothyroidism and antibody positive, the L-toxin supplementation significantly decreased the pregnancy loss and preterm births. So even if there is an insufficient evidence, the decreased risk of abortion in the TPO antibody positive euthyroid women and potential benefits if there has been a history of loss, about 25 to 50 micrograms of L-toxin, insufficient evidence, euthyroid women, thyroid antibody positive, that it would prevent preterm delivery. It's always a good practice to be on guard with these women because they can land up in issues. Now, if the patient is already taking one L-toxin brand, do you change it? And that's a common question that comes to our mind. It's always better to stay on the same LT4 formulation based on the concern that switching products could lead to changes in TSH that require TSH testing and dosage adjustments. Now, if you have women with thyroid autoimmunity and euthyroid in the early stages of pregnancy are at risk of developing hypothyroidism and should be monitored with TSH at least once in every trimester, at least up to second trimester. And L-toxin treatment can be considered in euthyroid pregnant women with antibody positive and history of pregnancy loss. So in case number 4, we conclude that history of abortions, preterm labors look for antibodies, and they give us an indication for risk of pregnancy loss, postpartum complications. If they are positive, treat, monitor 4 weekly serum TSH till 32 to 34 weeks at least, and counseling is very important for these patients. Now you have a 24-year-old primee in early pregnancy, comes to you with tachycardia, sweating, palpitations, dehydration, and hyperemesis. She has a palpable nodule near the left lower lobe, free T4-2 and TSH 0.1. What should we do? Now this clear-cut hyperthyroidism, and therefore, if it is less than 0.01 in the first trimester, does it need treatment, and how do you evaluate for suppressed serum TSH concentration is the question. Now, reduction in both the lower, that is decreased by about 0.1 to 0.2 milliliter international unit per liter, and the upper limit by about 0.5 to 1.0 milli-international units per liter. Hormone spillover syndrome, which is called as biochemical hyperthyroidism, can happen because of SCG stimulating the T and gives a biochemical picture of hyperthyroidism, usually seen less than 11 weeks. It's usually seen in multiple pregnancy, trophoblastic disease, hyperemesis gravidarum, and it is associated with extremely increased HCG levels, and thyrotropic subtype is seen to be increased. So as per the ACOG, undetectable TSH level or elevated free TI or both rarely associated with clinical hyperthyroidism, and no treatment is usually required. Routine thyroid testing is not recommended unless other signs of hyperthyroidism are present. And in our patient, we had those symptoms. So now if you have a thyroid nodule, and in case of a papillary or a follicular thyroid cancer, L-toxin suppression therapy should be initiated to maintain the serum TSH in the range of 0.1 to 0.8 and less than 2.5 for patients with medullary thyroid cancer. If the size of the nodule is stable, repeat biopsy should be performed only after delivery. Post-surgically, patients should be maintained on L-toxin with monitoring of TSH and free T4 levels every 6 weeks. And post-surgical whole body scintigraphy and radioiodine remnant ablation are contraindicated during pregnancy and lactation. And I have a couple of patients right now which, who have undergone this thyroid nodule change and are taking L-toxin at very, very high levels of 200 to 250 per day. A pregnant woman with a palpable thyroid nodule should be evaluated by measuring the serum TSH and an ultrasound assessment of the neck and the thyroid gland and an FNSE. And if the nodule is malignant or shows rapid growth, consider surgery in the second trimester. If the nodule is benign, no further evaluation is needed, except in the cases with elevated TSH. L-toxin is given to normalize the TSH and follow up with sonography of the neck. So in conclusion of case 5, increased HCG can present as picture of hyperthyroidism. Rule out hyperthyroidism by test only if other features are present. No treatment needed. Exceptional fall of TSH can be expected in the first trimester. Now you have a patient of subclinical thyroidism. L-toxin treatment is recommended in this, and it may be considered especially when the thyroid antibodies are positive. We've already discussed that. And it won't be recommended if the patient has no antibodies and has a normal TSH and the specific range of less than 4.0, you may just keep them under surveillance. So only TSH is raised and T4 is normal. There are no clinical features is how subclinical hypothyroidism is understood. And overt hypothyroidism will be when TSH is raised and there is reduction in the T4. And this has to be mentioned, and you must be well aware of these referral ranges and always can paste it on your, consulting table so that you don't forget it. Now, when do you test the neonate? Newborn blood spot remains the mainstay for accurate and timely diagnosis of congenital hypothyroidism. Thyroid function testing at 10 to 14 days of life does not improve diagnostic yield of congenital hypothyroidism in babies born to mothers with hypothyroidism. Postpartum dose management, LT4 thus should be reduced to pre-pregnancy levels and STSH assessed after 6 weeks. Hashimoto's thyroiditis usually presents postpartum. Increase the dose by 50% of the pre-gestational dose, and L-toxin during pregnancy for thyroid autoimmunity in the absence of TSH elevation. The L-toxin can be stopped at delivery with serum TSH assessment at 6 weeks postpartum. So the concluding take-home message for all of you, my friends, is I have a lot of cases, but I said we have to make it brief, and these are usually our daily problems that we face. And herein you have TSH, if it is a euthyroid, and whenever you are going to, so I think I've made it very clear when you will be doing the TPO antibodies, and then you have to look at giving them the correct treatment and the approach, and remember the mantra of 2.5 and 3 in the second half of pregnancy. So with this, I would like to say by what Dan Macpherson says, true prevention is not waiting for bad things to happen. It's preventing things from happening in the first place. Thank you so much for giving me a patient hearing and this opportunity to share whatever little I could on this topic. And I hope, Sneha, I've been able to make justice to what you had expected from me. Thank you.
Excellent, excellent.
Excellent.
Yes.
This is the only right word for the presentation. Excellent. And we really enjoyed case-based scenarios is always a very good learning experience.
You remember all your cases.
Yes. Thank you, ma'am, for sharing it with us. And Dr. Paresh sir, would you like to conclude the session? And
yes, it is an excellent presentation by Girija ma'am, and she took us from infertility till first trimester, second trimester, postpartum, when to do surgery, what is the role of these TP antibodies and everything. So, in all, an excellent message for everyone. 2.5 is a level which needs to be considered. 2.5, 3 in second and third trimester, first 2.5, and physiological increase in T4 levels initially because of HCG needs to be taken into account. Don't treat it as hyperthyroidism. So, excellent presentation, ma'am.
Thank you.
thank you, chairpersons. Thank you so much, Girija ma'am. Moving forward to the next session.
Thank you so much.
Let me invite my dear friend, Dr. Reshmi Banerjee and Dr. Alka Patel, madam, who's a senior practitioner in Vadodara, and herself, it's a charm for fetal medicine. So she's a FOXY certified sonologist, also senior, and a very loving persona, member of Society of Fetal Medicine, CME presentation of ultrasonography in mid-SOGO FOXY IRB. She is a faculty and has presented papers and state conferences. Special interest is in advanced 3D, 4D fetal ultrasonography, infertility, and laparoscopy. And she's also a Nightingale, sings so well. Welcome, Alka ma'am. And taking it forward, Reshmi Banerjee, who is National Chairperson CSR Committee, IMS, for 23-25. She's a life member of IMA, passionate practitioner, a good sonologist, and I know very devoted to her high-risk pregnancy patients as well. So, ardent animal activist, I cannot forget, we have a pet-friendly, different angle of friendship also now. So over to you, Reshmi, to introduce our next session speaker, Dr. Kuldeep Singh.
I would just interrupt Archana for a while. I want all of you to kindly vote for my dear friend, Dr. Sneha Buyar, and help her to become the Vice President of FOXY with magnanimous votes. Thank you.
She's sure to win, ma'am.
Yes, thank you so much.
Thank you,
Thank you
Archana.
so much, my dear. Thank you so much.
Thank you, Archana.
Thank you, Girija, for joining in spite of your busy schedule. And thank you so much for enlightening us. Thank you, my dear. Bye-bye.
Over to you, Reshmi.
Yeah, thank you, Archana, for inviting us to be chairpersons in this August webinar. And it's really, I mean, the content is, worth the scientific this thing. So even in this age of physical CMEs, webinars are still the way of life and academics. And best of luck to Dr. Sneha for the elections. And to carry the webinar forward, I would like to introduce, it's my privilege to introduce a person like Dr. Kuldeep Singh, who hails from the capital of our country and is internationally renowned for his skills in ultrasound and in OB/GYN and infertility. He is an international level faculty and has taken several talks in national international platforms, invited in several countries around the globe. Also, his books has been translated into many other in Spanish, Chinese, Portuguese, and has been internationally acclaimed for his achievements, and has also been awarded the Imaging Science Award in the AI Switch in Delhi. And not standing in between the academics and the audience, over to Dr. Kuldeep Singh. Looking forward to hearing your presentation.
Thank you, Dr. Reshmi. Thank you, Dr. Alka. Thanks, Dr. Sneha ma'am, for giving me this opportunity. I'm not going to take too long because I think so we passed 6 o'clock and there are plenty of you would be wanting to go back to your OPDs. So what I'm going to be talking about today is how we're going to be taking care of the fetal heart, because that's extremely important. I hope everyone can see my screen.
Yes, sir.
Perfect. And one knows that the fetal heart is extremely important, and it's just that we all tend to get a little scared about. So that's why my topic is not fetal echocardiography, it's fetal heart in anomaly scan. So that's how we're going to be placing on, and it's not necessarily whether you're doing an ultrasound or not. If you're getting it done from somebody else, this is what one should be aware of. So I'm going to tell you about basics. I'm going to tell you about how comfortable and easy it is. You're looking at the heart over there, and if you see if the baby is in a good position, you'll be able to see for all the views, starting off with the cardiac 4-chamber view, triple vessel trachea view. So we've done our transfer section by starting off looking at the fetal stomach, and we sliding a transducer from the abdomen to the fetal heart. Now we know everything of this is teamwork. You need an obstetrician, cardiac sonologist, maternal fetal medicine specialist, pediatric cardiologist, geneticist, neonatologist. If somebody's done an ultrasound and you figure out a problem. But if you're finding everything is fine, it's perfectly normal. And you need to remember each one of them is equally important. We have these various things that we need to be doing on our machine. The settings on a grayscale, it has to be high resolution, it has to be high PRF, the tissue harmonics have to be used. You need to be looking for cine loops because the heart is beating. So might be if you just miss out on something, use the cine loop. On color Doppler, you need less persistence, wall filter at the high settings, and the velocity so that the heart does not bleed. You do not see color coming out. Now, we need to remember that most cardiac anomalies are seen in patients without any associated risk factor. So you need to be looking at each and every heart in the anomaly scan. When I say every heart, means the fetal heart. Evaluation of the fetal heart has to be an important component of a routine scan. 12 to 14 weeks, you can do the earliest detection. 16 to 17 weeks, you can start looking at the 4-chamber view. 18 weeks, 4-chamber view, 95%. 22 to 24 weeks, 95% of cardiac anomalies can be detected. But we know ultrasound is operator dependent. You need to be watchful. And now we know because the termination is by 24 weeks, we can nicely do our evaluation between 20 and 22 weeks for an anomaly scan and looking at the fetal heart. You're doing a 4-chamber view, this is the sensitivity. You tend to look in at the outflow tracts, sensitivity increases. And if you do the short axis or the side views, you're able to look at 90%. What I always say at Sono School always is, and what I tell always is, if you're able to figure out this heart is normal, that's absolutely fine. If you're looking at a problem and you're not able to figure out what the problem is, at least you've not labeled an abnormal heart as normal, and you can then send them to a specialist. That's what our goal should be to start with. We're looking at situs solitus, where we're looking at the heart and the stomach both on the left side. We can have an abdominal inversus, where the stomach could be on the other side, thoracic inversus, where the heart could be on the other side. So we can have a situs inversus or a situs ambiguous. What at least we should be doing is, if we're looking at the heart and the stomach on the left side, chances of a cardiac abnormality are around 1%. If you're looking at both of them on the wrong side, in the sense both of them on the right side, chances are that there is going to be a problem of cardiac in 5% of cases. And if you're looking at one of them on the left and the other on the right, chances are as high as 80 to 90%. So at least make sure they both are on the same side. We're looking at the spine over there. We're looking at the cardiac apex. This is the apex. And we're looking at pointing to the left, that's the fetal stomach. I'm not going into the situs, the axis, the size, because that would take a little longer. So I'm just trying to tell you a rough format of basic and a little bit about extended cardiac examination. When you're looking at basic cardiac screening, it's a 4-chamber view that you're looking at. Simple chamber count. It involves careful evaluation of specific criteria. Cardiac 4-chamber view is the inlet view of the heart. Everything is coming inside. That's the level at which you're taking in. You're going to be looking at all the 4 chambers. We're looking at the spine over there. We're looking at the descending aorta. We're looking at the 4 chambers over there. Closest to the spine is the left atrium. This is the left ventricle, right ventricle, and right atrium. You're looking at a nice ventricular septum. That's the foramen ovale. Those are the pulmonary veins draining into the left atrium. And believe me, it's simple. You just need to have a practice and a knack of it. And that's what we follow at Sono School as well, is the eyes are going to see what the mind knows. And if anyone can do it, you definitely can do it. Foramen ovale, we're looking at the valves over there, bicuspid, tricuspid. You need to ascertain the fetal situs by looking at the stomach, the cardiac apex, the aorta on the left, than the IVC, which is on the right side. You need to start off with the transverse section of the fetal abdomen. From the transverse plane of the abdomen, slide your transducer up. You can get 3 types of cardiac 4-chamber views: apical, basal, axial, or lateral. The one video that I showed you just now, that's the lateral 4-chamber view. This is the apex. So we're looking at an apical 4-chamber view. That's the base of the heart. If it's at 90 degrees, that's a lateral or an axial 4-chamber view. And if this is 180 degrees, the base is going to be up and the apex is going to be down. Apical 4-chamber view. The only problem with the apical is you sometimes can be looking at an artifact where you're going to be looking at a pseudo VSD. Basal 4-chamber view. And if the spine is at the 12 o'clock position, you had it. You need to pray to the baby, make the baby happy, or roll the mother or tell her to have an ice cream and come back, because then you had it and you're not going to be able to see the cardiac chambers nicely. Lateral 4-chamber view. To look in for the septum over there, the ventricular septum, ideal view to be seen over here. Normal 4-chamber comprises of 2 atrial chambers the same size, 2 ventricular chambers the same size. You need to be looking at the cardiac squeeze as well. And if you're looking at a view which is perpendicular to the intraventricular septum like this, you're going to be looking at the completeness. And if you see this portion over here, that's the crux. Ventricular septum, atrial septum, and both the atrioventricular valves. That's the crux. Looking at the pulmonary veins draining into the left atrium. Left ventricle, right atrium. The IVC and the superior vena cava are going to drain into this, and the ductus venosus sends in a jet to the left atrium. So that's why you're always going to be looking at the foramen ovale flapping towards the left side. The 2 atrioventricular valves are also the same size. The atrial and the ventricular septa join at the junction, and I've shown you just now that's the crux of the heart. The right or the tricuspid valve inserts a little lower. That's the right one, that's the left one. If I draw a straight line here, this will be up, this will be a little more towards the cardiac apex. Apical 4-chamber view. You can nicely see the atrioventricular valves flapping over there. This is the moderator band in the right ventricle. That's the moderator band. Ventricular septum. You can sometimes see a flap like this, absolutely normal. Please don't worry about it. Foramen ovale seen over there. Pulmonary veins draining into the 4 sets. You'll be able to see 2 sets in the cardiac 4-chamber view. That's a gist of the cardiac 4-chamber view. Crux, both the septums, the atrioventricular valves, and the 4 chambers. What are the questions on four-chamber view? Is the heart position normal? Heart size normal? I'm not looking at any cardiomegaly. Ventricular chambers normal, otherwise that will give me a clue whether I'm looking at trouble. Is there a septal defect? Are the AV valves normal in position? And am I looking at any endo or myocardial abnormality? Now what happens is you're going to be able to see this portion on a four-chamber view, but you're going to be missing out on all this. So the limitations are the moment I need to be looking at the outflow tracts, the TGA, phallostetrology, truncus, double outlet right ventricle, and outlet VSD, aortic or pulmonary stenosis, or coarctation of the aorta, I'm not going to be able to see it on a four-chamber view unless and until these two things are very severe. You're looking at the four-chamber view was normal, but if you see over here, it's a parallel configuration of the vessels. It should have been a crisscross relationship. It's not there. So we know we're looking at a transposition of the great arteries. We're looking at a parallel configuration. Parallel configuration. There should have been a crisscross relationship. Normal four-chamber view, if I stop over here, I'm going to be missing out on this TGA. This should have gone this side, this should have come this side. You see over here, both of them conversing parallelly. That's a parallel configuration of the great arteries. That's why we need to do an extended basic cardiac ultrasound examination so that we can maximize detection. We don't need to be doing fancy stick, fancy this, fancy too much of color Doppler. Just use your 2D, be aware of what all can you, the potential that your machine has, the potential that you have, and you'll be able to figure out. If you say this heart is normal, means you've done these basic and extended examination. The outflow tract abnormalities, again, we know on a four-chamber view, you cannot detect them, but they definitely require early neonatal intervention. Now you need to be evaluating the outflow tracts. If you see over here, this is going this side and this is coming this side. The right one, the pulmonary artery goes to the left one, the aorta comes this side and again joins back. LVOT, RVOT. So there's a criss-cross relationship. You need to know that the great vessels are equal in size. Pulmonary artery could be a little bigger than the aorta. They cross almost at right angles. If you're not able to demonstrate or visualize these findings, you need to be doing a detailed fetal echocardiography. You need to be angling your transducer. So you're basically going to be from a transverse section, you're supposed to be rotating your transducer towards the fetus right thigh and the left shoulder. You will be able to get the right ventricular outflow tract. The moment you angulate it this way, that is the left thigh and the right shoulder, you're going to be looking in at the left ventricular outflow tract. I hope you're able to see me if I'm doing like this and I just do a tilt. I just do a tilt. This is how you're going to be looking at figuring out the outflow tracts. That's how you're going to be seeing them. The left ventricular outflow tract, it's basically the aorta originating from the left ventricle. You're supposed to be looking at the aortoseptal continuity. Anterior aortic wall, ventricular septum. And the posterior one, there should be a valvular aortocontinuity. Free movement with no thickening of the aortic valve should be demonstrated. This is what you're looking at. Anterior wall of the aorta should be continuous with the ventricular septum. That's the valve over there, the mitral valve, and it should be continuous with the posterior wall. Do not try it on starting off from 18 or 19 weeks. Start it from 28 weeks and gradually come down, and you're going to be doing a great job. Look at that. You started off with the four-chamber and you gradually tilting your transducer. See the aortoseptal continuity. This is almost like a five-chamber view. Aortoseptal continuity, aortovalvular continuity. See that now comfortably. You need to be patient. For doing an obstetric scan, you need to be patient. For the heart, you need to be even more patient. Looking at the five-chamber view and the outflow tract over there. The base of the aorta is the fifth chamber. When you're looking at the right ventricular outflow tract, it's basically going into the pulmonary artery. It courses towards left anterior of the ascending aorta, which I'll just show you in the video. It can be slightly larger than the aortic root, and it crisscrosses at almost 70 to 90 degrees. That is the pulmonary valve. It comes up, and there it's going to give you the right pulmonary artery going behind the aorta and the SVC, and then you're going to be looking at the ductus arteriosus. See that over there. We always start off with the four-chamber view. This is the left ventricular. Now we're coming on to the right ventricular outflow tract. Right ventricular outflow tract. That's the right pulmonary artery going behind the aorta and the superior vena cava. That's the pulmonary artery. That's the ductus arteriosus joining the aorta over there. This is the aortic isthmus. You're looking at PAS, and that's the trachea over there. That's the esophagus. This hyperechoic area is the esophagus. Plain simple, anyone can do it. You definitely can do it, so don't worry about it. You're looking in at the triple vessel view. All four chambers, you gradually coming up. You're looking at PAS. Why am I not able to see the superior vena cava? Because I've chosen a high velocity circuit. Superior vena cava is a lesser one. There you see that. Different color. This is blue because this is away from the transducer. Superior vena cava on the other side. The ascending aorta becomes the aortic arch, gives off arch vessels. The main pulmonary artery bifurcates into right and left pulmonary arteries. You're looking at both of them. Both of them should be showing you the same color. And if you see this is a dual mode, you're able to see the crisscross. Look at the crisscross. Flow towards the transducer, flow away from the transducer, because the aorta goes this side and comes back again towards the left side. Questions on the outflow tracts. Is there a normal crisscross? Is there a discrepancy in the sizes? And are the aorta and pulmonary artery in normal position as compared to the ventricular septum? All these are the transverse view. Cardiac four-chamber, we're looking in at the five-chamber view. You'll be looking at the PAS or the triple vessel view, and this is the triple vessel trachea view. We're looking at that was the left ventricular outflow tract, right ventricular outflow tract, and you're looking at the triple vessel and the triple vessel trachea view. The moment you're going to turn your transducer 90 degrees, you're going to start looking at the sag views. We're looking at the brachiocephalic. Now, when you see the sag view, this is the candy sign or the walking stick sign, and this is the ice hockey sign. Our hockeys are like this, but as we always come on from the west, the ice hockey sign is this one. This is going to be a candy shape. This is going to show you vessels on top. This is not going to show you. See over there. We're looking at the ice hockey sign. The anteriormost chamber is the right ventricle. We're looking at the pulmonary artery. This is where it is coming on. The ductal arch. we're looking at a bicaval view, superior vena cava, inferior vena cava, right atrium, and the posterior most chamber is the left atrium. So we're looking at a reverse hammock sign. We're looking at both the cavas. Now we're looking in at the aortic arch. So when we're looking at coming from right to left, first we're going to be looking at the bicaval view, then the aortic arch, and finally the pulmonary artery going more towards the left side. The sad sweep that you're looking at over here. The pitfalls, you could be looking at septation in the right atrium. Not to worry, that's normal. Bright spot apex, the echogenic intracardiac focus, a pseudo VSD or a ASD, and pseudo pericardial effusion. An effusion or an anechoic collection in the anterior portion only of less than 2 millimeters is regarded as normal. We do a quick view again of the four-chamber outflow tracts, right pulmonary artery, and believe me, it's very interesting. Keep one of those thin patients for the end after your OPD and try and do this. You're going to love doing the ultrasounds. So the steps basically for a segmental analysis: identify visceral situs. Which side is the stomach? Identify atrial arrangement, atrioventricular connections, ventricular arrangement. Look at ventricular-arterial connections. Look at the arterial trunk arrangements and identify the systemic and pulmonary venous connections. You're going to be doing it carefully. You're going to be doing a step-by-step analysis, and you're going to be doing wonders when you're evaluating the fetal heart, even in the anomaly scan. Thank you. Thank you so much.
Thank you so much, sir. Thank you so much, sir. It's my immense pleasure to chair the session. Thank you, Archana and Amita ma'am, for giving me the chance. And thank you so much, sir. It was a brilliant talk. Okay. And as all of us know, it's always immense pleasure to listen you, privilege to listen you. And you are the Mahaguru of sonography, really. And we all know that fetal heart is a very, very complex organ to be imaged. And you made it so simple and very, very easy for the obstetricians. And as all of us know that the 90% of the congenital heart abnormalities, they do occur in the very low risk population. So we all, it is our responsibility that we all obstetricians should learn the basic heart evaluation regularly. And so we can pick up the points, and if we pick up there is abnormality, we can refer to the tertiary center where all expertise is available, HAR and machines are available. And so perinatal mortality and morbidity is avoided by in-time treatment. And as Dr. MC Patel sir very correctly told us that if anything happens to mother, we are responsible. If anything happens to fetus, then also we are responsible. So we have to look after the two patients. So it is very, very important. And so we have to educate the people who are involved in the obstetric examination of the fetus. And so the fetal, we can prevent, we can decrease the fetal mortality and morbidity. One thing above all that I would like to add is first trimester anti-estimation. That is very important because increase the anti is directly associated with the increased incidence of the cardiac abnormalities. So and above all, anti within the euploid, increase anti in the euploid fetus, microarray analysis would be more important. And if NT increases from 2.5 to 3.6, it is 1 in 50 is the incidence of cardiac malformation. And if it is more than 6.5 or like that, it is 1 in 5 cardiac malformation. So first trimester NT, all obstetricians should learn to measure. Second thing is NT more than 99%, we should directly refer for the fetal echo. along with if it is more less than 95%, about 90 between 95 to 99% with TR and this abnormal DV flow, then also we should refer for the fetal echo. So this first trimester analysis is also very important. We all should learn ductus venosus and tricuspid. Second thing is machine settings are also important, as sir said, because of the if settings are not improper, then we can have the false positive or false negative results. So we should try and we should learn the machine settings, and it is individual for all the people, and we should make it preset also. Third thing is we should use routinely M mode to know the rhythm abnormalities also. So that is also very important, very strong. So take home message is always take time. It requires time to scan the fetal heart. So we should not be in the hurry. It should take time. Always examine systematically when the fetal back is posterior. So when fetal heart is anterior, that is one of the tip. We can see the fetal heart very properly, and above all, use the checklist. So that we have to document all the findings. So we should not miss anything. And third thing is scan opportunistically. Whenever you find some abnormality, you should scan it in detail, or if you don't know, you have to refer to the tertiary center, and be patient if visibility is low because of the improper position of the patient or the obesity. But you have to document that due to this problem it was not seen, and call the patient. Either you make her to move or change the position, or you call her the next time. So this is the tip. Thank you so much, sir, for giving such immense knowledge. Thank you so much.
Thank you, Alka ma'am. Thank you, Reshmi, for chairing the session. And we owe this to Sneha ma'am. I'm interacting with sir for the second time. It is always a marvelous experience, sir. And
I just wanted to say two things. Thank you, Archana. This was really lovely, and it's just a smooth running. Thank you so much. And again, a request from my side as well for Dr. Sneha ma'am. Wonderful person, wonderful academician, and we definitely are supporting her. And we want everyone of the society and everyone to be voting for her, because not voting is not going to really do it. Voting is really going to be the thing that's going to be useful. All the best, Dr. Sneha.
exactly, as sir has said, I request everybody, please vote. Yeah. Voting is your right, because candidature is there in front of you, but if you don't vote, we are at loss. So voting is very, very important.
Yeah. My namaskar to Dr. Mahendra Soni, sir. Sir, namaste. And I'm very happy that all the seniors have joined. Dr. Pankaj Desai has personally called me to give his blessings, and I'm very happy to have all of your blessings and wholehearted support. I'm basically a private practitioner like majority of you, and yes, I have a passion to continue with my academics as well. So that's the biggest asset, that I like to interact with people, and definitely would like to meet all of you. Thank you so much for all your loving words. Thank you so much for your support. Sir, I need your blessings and support, sir.
Sure.
Thank you.
Thank you. All the best.
Thank you. So as a formality, I have to give the vote of thanks to everybody. I mean, the delegates, the faculties, the topics were so excellent. Thank you, Sneha ma'am, for choosing these topics and giving us the platform to learn more and more. And the Surat Society, our own Baroda Society, Palanpur, and Himmatnagar. We are really happy for your active participation and requesting support and heart that please do vote. And Sneha ma'am is a very good candidate. Not miss the opportunity to do so and have a proper candidature with us. So request to vote, and thank you for joining us. Thank you, our platform providers, Saiti and her team. It was a smooth running program. We had a thorough thing. And thank you, Sneha ma'am, for again choosing such good academics. As academician you are. I know you from years, your hard work, and coming from a small place, we're making a larger platform in Foxy is a real hard work, ma'am. Thank you. We owe and you are.
Thank you so much, dear Dr. Archana, Dr. Kirtan, and Dr. Munjal. I have built up the, goodwill all over the country, and these are the people who are really the backbone of my, they are the real strength for me. And thank you so much once again for having us here. Thank you. Thank you, everyone. Thank you so much.
Signing off for meeting again together somehow.
Yes.
Thank
Yes.
you. Bye.
Thank you so much.
Thank you. Thank you, Alka ma'am. Thank you, Archana.
Thank you, sir.
Thank you, Sneha ma'am.
Thank you, sir.
Thank you, Soni sir.